Are we online?
We're not live yet. We're still
Right.
pre-live. Matt, we're good to go whenever you are. We're live.
We're live. Good morning, everybody. Welcome to the board meeting. It may be a bit rainy out there, but hopefully we'll have a good meeting here today. In terms of what we've got today, we've got to welcome John, your first board meeting. Susie's on leave, I believe, today, so otherwise it'll be her first board meeting as well. Andrew, welcome.
Thank you.
And what we've also got to say is also, clearly this is the first board meeting post Alan leaving. So both Alan and Simon, since the 1st of April, are no longer with us. So this is KTH not starting afresh, but certainly moving on from where we were. So welcome. And first of all, we've got a presentation from two colleagues from Cancer and Macmillan Information Centre. Oh.
Yeah, thank you. This morning we have Ruth Giles, who's our head of nursing for cancer, and Danielle Mellows, who's the Macmillan Cancer Information Support Service. It's a very exciting one, isn't it? So I'm pleased to ask these two to come along this morning just to talk about our Macmillan Centre, which is an amazing facility that we now have for the patients in the morning. It's very exciting. We've had various people come and visit and open it. We had the Earl of Spence not so long ago. It is an absolute fantastic facility. So I'll just ask Danielle and Ruth just to tell us a little bit about it and what it's doing for our patients. It's such a fantastic facility. So over to you, ladies. Thank you.
So I'm going to start. I've been here since 2014, and my first experience of coming to Kettering, I was really surprised that we had the only information support resources we really had for cancer patients were 2 trolleys on wheels, which you could put leaflets in, one in the treatment centre and one down in Centenary Ring. And I've sort of made it my mission since I've been here to try and improve that. It's obviously taken an awfully long time, to sort of 9 years really, to get to the place where we are now, where we worked in collaboration with Macmillan, who gave some of the resources, and we gave the other half of the resources to build what we have got at the moment, which is a fantastic facility. I think another thing to be really proud of is the fact that actually when we've finally got the opportunity to demolish the old building where it's situated, the builders and everyone came together during COVID and basically managed to get the project from demolition to the first patient coming through the door in 8 months. And I think that if you look at the geographical area that it's in, you will see that that was really challenging, and I think it was everybody's commitment. COVID was both a difficulty but an opportunity too. So that's kind of pass over now to Danielle in terms of what services we provide there, but we're obviously happy to show any of you around at any point if you want to come down and visit the centre and actually see what the fantastic resource we've got.
Thank you. So the aim of the service is to provide an holistic approach to supporting people affected by cancer, so whether that's the patient, a carer or a family member. So it's around providing a non-medical support, so that could be practical support, emotional support, financial support. And the whole idea is to be able to provide a person-centred and individualised approach to information and support, because we know that everyone's needs are different and their needs are different at different times of the journey. If we can just go to the next slide, please. Sorry. So basically we offer information and support through either telephone, email and now face-to-face, which is really important because we know that people really value the face-to-face support. So we offer things like emotional support, counselling, and we offer support groups and coffee mornings, so bringing people together in a safe and comfortable environment. And I know Debbie did attend one of our coffee mornings recently. Some of the main things that we deal with are things like talking to children about cancer, to parents and grandparents talk to their children and loved ones about cancer. We do a lot of financial support at the moment, covering the cost of living crisis, because that's a really important thing for people, and some of that is about returning to work as well. So some people return to work early on following treatment because they can't afford to do work. It's about what we can do financially for them. And the most important thing about the centre and the service that we provide is very much about that emotional support. So very much people feel that they are supported from a medical perspective, but they don't always have people to talk to, and their families don't really fully understand some of the things that they're going through. So we provide that safe environment for them and can link them up with other people with that shared experience. And if you just go to the next slide, please. So as you can see over the last so I started in Q1, and that was before the centre in 2021, and that was before the centre opened. So at that point we were still going through COVID, and it was very much telephone-based service. And as you can see from the graph, we've quite rapidly increased our interventions with people affected by cancer, and the yearly total for last year was over 1,600 people that we saw and had the interventions with, and that does include staff as well. So staff have also found the service valuable, either for themselves from a personal perspective or to help them support their patients. I'm really proud of what the service has achieved and what we can provide and offer for people across Kettering and surrounding areas. It really has been about making an individual's experience as positive as we can and making sure that we get them the support that they need at the right time. I think for me going home, I really go home with a warm feeling that when somebody's come into the centre, that actually I go away knowing that we've made a difference to that person's day and their journey. So when they've come in quite distressed, they can walk away with a smile on their face.
I think also the other thing to do, before the centre that we've got, the patients would have to travel all the way to Northampton. So, and obviously in terms of being quite a poor area, you know, they weren't going to travel by well, there aren't public transport links to Northampton to get information and support. So to have this here, and also now, obviously, Northampton do have a centre, so we're in a position of working collaboratively together and offering more services to the patients of Northamptonshire, really, which I think is a real opportunity. We've had opportunities to kind of run walking groups together in different places. So just really proud, really, and I hope to utilise it more as a hub and spoke to take information out for patients and their relatives. And I think that's the other thing, as you said, staff have used it, but also we sometimes underestimate the impact on relatives and loved ones, and they sometimes need somewhere to sort of pop into to get information so they can support their family through the journey, as it were.
So thank you. Has anybody got any questions for Andy and Ruth?
So yeah, no, I'm obviously really pleased that it's open. I remember you guys coming to Dragon's Den all those years ago to get some funding for it. I know there's lots that's happened. I was more of a question of people that are in the communities or post treatment. Do you get many people coming in that still use the centre that aren't actually under hospital treatment?
Yeah, so we see, I would say we see a third of our service users after treatment is finished, because we know that actually when treatment ends and kind of the medical appointments stop, then that's when people find themselves most lonely and struggling to deal with the psychological aspects of going through the cancer journey. And we have some people that have probably been a year finished treatment and they're still attending our services and courses. So what we do in collaboration with Northampton, we put together a health and wellbeing perspective. So that shows all of the courses that we run and workshops over the year. So we run them as a hybrid now. So people join either face to face or online, because we know that for some people it's difficult getting into the hospital, especially if it's an evening one if they've got children and things. And because we're currently always like updating the courses and stuff based on the feedback, there might be a new course that appeals to somebody. So yes, that support doesn't stop just because their treatment has stopped or they've been discharged.
That is
to carry on.
And that is often identified as one of the most difficult parts of recovery. You know, it's great when you've got all the challenges of going through the treatment, but actually when you're being followed up regularly, that's almost kind of quite reassuring. And then when it's like, well, over to you now, go, you're free to get back on with your life. It's like, well, no, really, people don't feel able to.
Lots of people do find going back into a new normal, as they call it, really challenging, and fear of reoccurrence is a key thing that we cover following that, because people, every little ache, every little pain in their mind is it cancer returning? So that's one of the things that we cover quite a lot. Helping them to kind of go back into this new way of living, whether that is returning to work, or whether that is going back into society, because a lot of people stop socialising and become quite isolated through their cancer journey because they're worried about picking up infections, or they've lost their confidence, or they just kind of feel that they're just not in that frame of mind to meet other people.
Jane and Andrew.
Thanks, Chair. You're absolutely right. You should be proud of these services and the impact they have on patients, their families, and that wider group. What can we do better to look after all of you? Because this is hard stuff that you're dealing with every day.
I mean, in terms of you've got clinical supervision, we have clinical psychology service, and psychologists are the only service that we've allowed to utilise the rooms within the centre. But so the clinical psychologist provides support to the centre staff, but also does clinical supervision for the cancer clinical nurse specialists. And they have the opportunity to meet there once a month to go to have a team session or individually.
I think just adding on to that, not necessarily from a staff perspective, but one of the things that our search users really struggling with, and it's probably come up so many times, is car parking. So often we've had people not attend a coffee morning or a workshop because they've had to spend an hour parking and they've given up, so they've dropped out of the course even though they've signed up and looked forward to come in. And we're getting a lot more inquiries about people going over to Northampton now for radiotherapy around the cost and travel. So if somebody doesn't have a car or family support, then they really struggle and can't afford to get a private taxi over there.
And that is a deficit in this area. I previously worked in Cambridge, and there was many more kind of voluntary services that would all help patients bring them backwards and forwards for radiotherapy, particularly, than in this particular area.
And I think from a personal perspective, that's probably quite challenging, having those conversations with patients that, we all signpost them to voluntary services, but like Ruth said, a lot of the voluntary services are oversubscribed now in capacity, or they haven't got the funds to continue. And that can be quite challenging with people. And through Macmillan and their grants and with the financial welfare benefits, there's only a limited amount of money that we're able to get for patients to support with the travel. So if there's anything, we can do potentially to support that, I think that would be really beneficial for both patients and for staff having that, because it's quite tricky to say to somebody, oh, actually, we can't really, support you any further with transport because you've had a grant, etc.
And just in terms of patients going through their diagnostic journey, I mean, definitely I've been involved in cases whereby patients don't come to hospital, or they can't come because they can't afford to get here. And it's, and it's even more difficult in the pre-diagnostic stage because they haven't got cancer, so you can't necessarily apply for those grants and things for them. So we do have cases where, people did not attend, and you find you go in. For me, it's a big issue. The patients that do not attend, people say, oh, they've got responsibility to come to their appointments. But in every single case I've been involved with, there's a reason why they don't attend. Most people do not come to a diagnostic or a cancer appointment unless there's a really valid reason why. And it's whatever you can do to try and help support that, really, to get them to attend.
Yeah, thank you very much for the presentation. I'm the Vice Chair of Breast Cancer Now, so I found it particularly interesting. Of all of the services that you provide on the list that you put up at the beginning, what would you say are the most popular?
In terms of overarching themes, emotional support and financial support are the two biggest things. Our finance, we have welfare benefits, citizens advice service on a Thursday that comes in, and the past 3 months they've been chock-a-block with appointments back to back, and we're doing more and more referrals. Just as a bit of a guide, last year we submitted the Macmillan grants, which is a one-off payment of £350, and what we got back for patients was over £22,000. So that just, it's only £350, but it just shows how many of those grants that we're processing and getting that money for people. And then obviously the emotional side, so whether that's one-to-one or group support, is the other big thing.
It will be interesting to see how we do in our National Cancer Inpatient Survey, because prior to the centre, emotional financial support was by far the largest element that people were having concerns about. So it would be interesting to see, you know, after a couple of years of the centre, it's always like retrospective results of the survey, but whether or not we shoot up, for hoping's sake.
And you link up with the Citizens Advice Bureau as well?
Yeah. So Macmillan have funded welfare benefits that sit within CAB, so we can offer quite a low level financial support, and then they come in and they do all the kind of detailed work around, you know, what they try to do is maximise any income for and if anyone knows the benefit system, it's quite complex. So they come in and do the full checks, and then we help people with filling out PIP forms, attendance allowance forms and things, so we support them through that process.
Thank you.
I'm going to turn actually to Polly for a minute. Polly, in terms of people getting in, the diagnostic up at Corby, is that likely to be sort of help those that are living on that side of the county for access?
Yeah, for access, absolutely. I noted that comment down as well, in terms of picking up what we can do with the local kind of voluntary sector and transport, particularly with the strategy about radiotherapy across the group, and there'll be more patients that are potentially going to Northampton. So I do think that's quite an important thing that we need to pick up. So I've noted it down. I'll come back to you.
Any further questions? Oh, sorry.
Thank you. Thank you very much for the presentation. It's really humbling, and actually your pride for the service is really clear, and rightly so. It was great to see on the slide patient and staff feedback that you've gathered. So my question is, how do you gather that feedback, review it, and then have we got any examples of where we may have taken action as a result of that?
So on all of our information booklets and stuff, we have set a QR code so people can go on and do the family and friends test, and it's aligned to our centre. And we also, for all of our courses and these, we send out an evaluation form as well, so that helps us to you know, rejig some of the content and stuff to make sure that it is fit for purpose and actually people are getting what they want, and some of it's anecdotal as well. So when people come in, you know, they will make a comment and stuff, so we're trying to capture all of that as well. But we also have an MQuEN, which is the Macmillan Quality Environment mark coming up, so that's the gold quality standard that we've been assessed for in May, and as part of that, again, we have to collect patient and staff feedback, so we'll often email out questionnaires and things, and ask people to share their story and their experience using the centre as well. So there's various different ways.
And I think also, I mean, when we looked at the centre, in terms of we provide a wide variety of resources, there's not one size that fits all. So obviously during COVID we couldn't do face-to-face, but then that enabled courses to become virtual. So you've got a sort of a range of and diversity. So hopefully you're getting the right fit for different people, because certain people wouldn't want to receive services it needs to be individualised and receive them in an individualised way, really.
I think not having the centre during COVID actually became quite beneficial to us in terms of developing some of the online work and the YouTube videos that we create. I'm running courses online, and we run a 6-week HOPE course, which is a self-management programme helping people to take back some control. And we were the first hospital, along with Northampton, to deliver that online. And now lots of centres across the East Midlands are now trialling that online. So that's really positive from our perspective. Actually, we're the ones that kind of said, let's give it a go and see how it goes. So, and now everyone's following suit, so that's really positive for us.
Thank you.
Yeah, thank you. Thank you both. I'm really interested in some of your data that you're collecting and how you've described actually the health inequalities that we've clearly got across this county. And I was just wondering whether there's an opportunity there maybe to dig a little bit deeper. And I don't know how rich your data is, but I can see Lee's over there in the corner. And I was just thinking, you know, this would be a huge opportunity to really delve into the data and have a look at what that profile looks like across our county. And then we can start to look at what else can we do, because the CDC is a really fantastic opportunity, you know, a start towards that. But actually, just thinking about the breast ladies, they have to come to Kettering, don't they? Or they have to go to Northampton. So I guess it would be really, because it's quite stark actually when you describe actually people can't make it to radiotherapy because they don't have the money to get there. And I think it would be remiss of us not to have a look maybe at our data that we've got and see if there's any targeted areas we can perhaps focus on.
Yeah, so we collect data based on Macmillan standards because we have to report to Macmillan on a quarterly and yearly basis with all of our data. So they do capture quite a lot of data, but I think if there is data that we're missing, or then, you know, we can look at ways that we can incorporate that as part of that Macmillan data that we use for our own personal sort of KGH perspective as well. I'm happy to talk to anybody around what we collect as standard for Macmillan and then anything else we may need to get that richer detail.
Okay, thank you.
I just want to take that stage further actually, because I think one of the things that the Integrated Care Board or Integrated Care System is supposed to be about is actually targeting inequalities. So actually it's bigger than the organisation. A lot of those travel and transport issues are ones that we need to be in dialogue with the local authority about. I'm saying it's all the local authority, but you know, they are part of that picture. So I think that's a wider discussion. So I think we need to be making more links with the ICB about this discussion. I'm sure people are aware of it, but probably not as aware as they need to be. Hard information helps in those conversations.
We can help support because the strategy team have quite a lot of information about the local health inequalities and the pockets. So if we collect postcode information, we can be able to quite clearly overlay that and see where the access is and isn't.
And it was one of the metrics when we talked about community diagnostics, we said
Absolutely
putting them in those two sites was to improve access
Yes.
and to make sure it was people who were disadvantaged were accessing them rather than everybody else.
And there's the physical access, but then there's also, if there are transport problems, your virtual and your online classes, do they have the digital capabilities and technologies in their homes to be able to access those as well? So it's kind of a multitude of things, isn't there?
I've just cautioned with the use of sort of data that says this area is you know, an area where well-off people live. Some of the rural communities in Northamptonshire, which would be in areas that don't look deprived, will have farm workers, poorer families, and actually internet access in those areas is still quite poor. So I've just cautioned against that really. Just look at your data probably more than, well, use it to complement you.
Well, thank you very much. Thank you also, Ruth, for your perseverance over all these years to get us over the line. You know, it's one of those services that when it's up and running, you think, how do we manage without it? And I've got this mental image of your trolley being pushed around. And unfortunately, I've been to too many hospitals over the years where I've seen those trolleys being pushed around with the out of date and the leaflets falling off them, etc. So both of you, thank you very much for what you're doing. And actually, I think, you know, there seems to be a huge additional benefit. I don't know whether anybody thought about it beforehand. What we're gleaning from what you're doing, the information, you know, spent a lot of the time here talking about information. That information and how can we make access to the services better going forward and more, yeah, clearly more accessible. It's a public meeting, so you're welcome to stay.
All right, thanks.
Just arrange.
Mm.
And I think we all know each other, but swimming and tackling. My apologies. I should have given apologies before we started that. So apologies from Debbie Needham, face covering for Debbie, Matt Metcalf, got long teeth in today, and Richard Apps. Apologies. Thank you. I would hope that we can build on that information that we just heard. Is there anything anybody wants to say before we continue on from what we've just heard? Anything further? Alice.
Okay, it was just a question I asked Polly actually, because I thought we were running short of time in that session, but I was asking about the sort of the funding and management of that centre going forwards. And Polly's view was that we had a commitment from Macmillan to fund that for a period of time, but presumably we need to look in the long term to fund and manage that. John's nodding. Yeah,
that's the case.
Yeah,
with
yeah,
that's
yeah,
much all of-
yeah, okay.
You have to commit.
Yeah, so that's something presumably which would be in our long-term plan or our medium-term plan. I mean, normally 3 years, isn't it?
Yes.
It's normally 3 years, yeah, and I think what we need, sorry, I wasn't here for the original business case, but clearly we'd need to look at kind of the benefits of it, of which it sounds like there are many, and kind of how we can leverage that for the wider organisation.
Yeah.
I was going to say that the usual way is for that conversation then to be had up with commissioners and other organisations, because it's not something that's a benefit just
Indeed.
to, it's a benefit to the patients. So how do we maximise that across the system? Deborah.
So charitable funding, so provided it's not maintenance, because some of this funding came out of the local charity.
Sure.
Provided it's not regarded as maintenance. So let's say there was a development initiative, then they could apply to the local charity for that. So yeah.
Thank you.
Yeah, good. Yeah, thank you. So minutes of previous meeting. Any comment on minutes of the previous meeting? No, we'll accept the minutes of the previous meeting as given. Susie is on. Is she?
We were expecting Susie. Her update to Northampton yesterday was to bring back some metrics as part of a refreshed comms strategy in September. This was an outstanding action relating back to Teresa's time around metrics around the comms framework. So that's I think the update that she would have given.
Right. So that will still be a matter outstanding for them.
But with a date on it now.
Yeah. Good. The ICB committee, this matters arising, the ICB request for us to consider about whether or not we should have non-exec sitting on the ICB committees and vice versa. This is still outstanding. It's a part of a wider conversation we need to have amongst the non-executive directors and with the incoming chair about how we want to work with the ICB going forward. Certainly, I think one thing that has been consistent from anybody I've spoken to around this is we would not want the involvement of non-execs to be at the detriment of the involvement of the executive directors at the ICB, which is where the ICB had started from, and we're still concerned about the possible conflict of governance that might arise if we're sitting on the ICB committees and the ICB is sitting on our committees as a sort of matter of course. So that's still going to be a matter of open matter. Certainly I've been in discussion with Rachel at NGH about this so that we make sure that we've sort of got a consistent approach across the two trusts. Chris.
Have we had any feedback from other ICBs, how it is being handled? And have we had a legal opinion about the conflict of interest? Because I really do not understand how you can be a non-executive director here and a non-executive director on a committee of the ICB. it just flies in the face of transparency and interest.
Yeah. Thank you, Chris. I think that point, I don't know whether we have, but Richard was looking at it along with the other governance leads across the lead system. So we will put that back to Richard when he returns. And John, the SFIs.
So SFIs, this morning, apologies for the tardiness, Chair, sent a re-clarification through to Richard this morning where I've tidied up the table that was requested. I've removed any reference to group board because it doesn't exist. I've updated it to say solely trust board of directors, and I have I've removed the reference around group CEO and trust CEO to be. There was that was for kind of capital spend above 3 million, and then for anything up to 250k have changed it to be group CEO. I know there is an issue at the moment. I will work through what interim arrangements mean for that, but to refer to group CEO and group CFO solely. So I've tidied that up and that's been circulated.
Okay, thank you. So rather than bring that back to another committee, we'll circulate that out of session,
please,
to everybody.
Yeah, apologies for that.
Providing there is no adverse comment, I will take chairman's action to approve those because we need those in situ now rather than waiting for another meeting. Okay. Anything else on matters arising? John.
I had another open action on the action log, Chair, around conversation around preparing a policy statement preventing unfunded additions to staffing establishment. I've reflected on this, and I think, and sorry to put Paula on the spot, I believe that given the arrangements that we have in place around a vacancy control panel, which is chaired by a number of us around this table, it's an executive chaired meeting, and the processes that are embedded now within people and within finance, there isn't an ability to recruit to a post that there isn't a challenge on funding. So rather than write a grandiose statement, I think we just need to operate the processes that we've now put in place.
I'm comfortable with
Please.
That's the assurances, just to see that diagram of the governance process, just on a single sheet.
Thank you. Nothing else on matters arising. Faye, Chief Executive Report.
Thank you. So firstly, I'd like to send Debbie's apologies. She's having a small operation, or she's had a small operation, and therefore she can't be with us. She's hoping to be back, however, next week. So there are 4 things that she's asked me to bring forward today. So first thing is around the Junior Doctors Industrial Action, which is taking place next week for 4 days. Preparation is going really well. Actually, I think we've definitely learned from the previous strike. So plans are very much in place. The recent industrial action we saw many of our nurses and doctors supporting our patients and doctors on the wards. And Debbie would just like to really thank everybody that's helped keep our patients safe, because it's been very difficult for staff, particularly when we're asking them to sort of step down and cover, but certainly our nurses and our doctors have been very supportive, as have our consultants. So the next week we've got 4 days of strikes, which again is testing our resilience, but we are hopeful that the BMA and the government will agree a deal soon and cease further action, because of course this is having a major impact on our elective care, particularly in terms of cancellations of patients. But I think the most important thing is that KGH has definitely come together in terms of making sure that the patients are safe during those 4 days of action, which we previously had and we are planning for after the bank holiday. The second thing Debbie's asked me to raise is our programme of improvement for children's and young people services, and this continues to make really good progress. There is clear evidence that improvements are making a difference to our patient and families, but without doubt there is more that we have to do. The inspection report is expected to be published next week, and Debbie looks forward to updating our community on the changes that we have been making in respect to our the inspection findings. Today on our board agenda later, we will hear about the response from last year's staff survey. The results are disappointing given the amount of work that we have done, particularly the engagement work and how we've involved staff. Without doubt, there is more that we need to understand from our staff and experience in the 4 areas of compassion and inclusion, recognition, engagement and morale. We will continue to focus on the priority areas that we set out last year, and we will be engaging with our staff again. We will be undertaking over the next few months a discovery period, and that will take which I'm sure Paula can add to as a period of time. But I think it's important to note that we won't see those changes immediately. Cultural change, as you will know, takes can take several years. However, once we've undertaken the discovery phase and that is completed, we will be pleased to update the board further on progress. Finally, Debbie has asked that we recognise the learning and development team at this board for hosting 2 work experience evenings in our hospitals. Debbie and I both had the privilege of attending these, and the first students that came through were students interested in potentially a career in medicine. 150 young people attended on this particular evening. The second evening was for those wishing to enter nursing and midwifery careers, and over 100 attended that event as well. So both of us went round and spoke to the young people of the future, which was really heartwarming, and the vibe in the room was really amazing. Actually, there's so much energy. So Debbie, again, would just like to thank the learning and development team and all of the other people that came in their own time to support that event, because it really was a really well executed event that evening. So I'm sure all of you will pass on our thanks to your team. Thank you, Trevor.
Thank you. John, I didn't know whether you wanted to say anything specifically about the strike in this session.
Well, what I would say, just echoing what Faye said, we spent, Faye, myself and James spent a fair bit of time looking around the wards last time, and I was really impressed with how the consultants were dealing with it. I think it's probably a bit too much to say that we're enjoying themselves, but they did seem to feel that they were really well supported, and I was particularly impressed by how some of our nursing staff and DHPs stepped up to support that. I think the ask is going to be a little bit more difficult this time, not just because it's an extra day, but because of when it comes. So there's there's people on annual leave who we do need to honour the annual leave for those people. And let's hope we get a resolution pretty soon.
Is there any questions for Faye on Debbie's report?
Could I just come back to the 2 marvellous events? Absolutely brilliant. But can I just ask, are we going to have a third one that covers all the other?
Absolutely.
Like healthcare scientists, estates, etc.
Yes, definitely.
There's a series of 4, Chris,
Excellent.
about all professional groups, and they've been hosted here, but they've actually been promoted across Northamptonshire, and we've had people coming from as far as Birmingham, Norfolk, all sorts of people. And I did also go to one of the evenings, and they've been fantastic, and a real team effort with lots of colleagues from across the hospital coming to talk about their area of expertise.
Yeah, it was really excellent. At the nursing one, there was all different stands, and they got the opportunity to have their arms plastered and do an injection, and there was some freebies there as well, so they're collecting all the sweets and their pens and stuff. But yeah, there was a really excellent vibe, wasn't there? Really good.
Someone talk about professional groups, that includes people such as yourself as well.
Yes,
Yeah.
yes, and there's a non-clinical evening as well, yes.
Yeah.
And I've spoken to Sheila about running parallel events from Northampton in the autumn, so we run this as a cycle.
Natalie and then John.
And is there an element of kind of lively participation within those, so that you're going to groups who perhaps might not have thought about going to university, that's required for that role, or who just wouldn't traditionally have been associated with those kinds of roles? Is that an element as well?
Yes, and we do quite a lot of work out into schools and also with the Jobs Centre, with MenCap, with different charities to try and extend our reach, as you say, to those people who might not otherwise have considered coming to join us. And certainly I think for me, place in my context means us thinking about how we can become that anchor institution to actually encourage people into employment here in whatever way suits them, because we've got so many different career opportunities, haven't we? And I really think we need to think about how we're opening up those learning opportunities to create different pathways to encourage people.
John.
Yeah, just on the back there, the workforce recruitment, but I think there's a real opportunity here. So I've been in discussion with University of Leicester, together with Hammond and Matt Metcalf, around how we can support the upcoming expansion of undergraduate medical students, which looks like that's going to happen in about 2 years' time. It looks like more of the same, i.e. a joint orientation hospital is not going to be the solution, so there's a real opportunity for us there. But also Leicester and De Montfort are branching out, and they've got other courses, they've got EHPs, they've got physicians associates, so there's a real opportunity for people. We need to just make sure we prepare ourselves to be able to do that, because we all need some infrastructure behind that to support our academy. Is popular with undergraduate medical students. It's reasonably accessible from Leicester, and the feedback's good to follow. That's my understanding. It's a real opportunity, but we do need to get ourselves organised.
Good. In terms of my managing the agenda, apologies. I should have given the chairman's update before it was the chief exec's update. I blame my scribe to the right. I know I briefly mentioned at the beginning, just to make sure that we've got Alan after two numbers, 49 years, I think 47, but whatever it is, 49 years of health service experience, whether in the NHS or other sectors, retiring as the chairman. I think that needs to go as being marked on our minutes, that actually we want to thank him. And I sit around this table, one of the only non-exec, a couple of execs around 6 years ago when he came to Kettering, and things were in a very bad state. So things have moved on considerably. We've still got a lot of work to do, but that's a major move. And then of course Simon in as chief exec, initially to Kettering and then later to NGH. So also recognise that Simon's departure as well formally in the minutes. And lastly, congratulate Debbie on the CEO appointment, interim CEO appointment. I should also say that the Council of Governors also approved me to chair the meeting. So I think that's thank you. And if we then move on to the integrated report.
Thank you, Chair. Okay, so back to you, I think, Chair, for
Yes.
the Strategic Development Committee. Thank you.
Yes, well, it's largely as written here, the four major items are there. So we've got the project management, and I think this is something, it's work in progress, but it is actually for the senior responsible officers to take accountability of their own projects at the Strategic Development Committee, rather than everything being reported through the project team. So that's quite a significant change there. Energy Centre, this actually is very good news. For those that are new here, haven't visited the temporary boilers sitting on the back of the trucks out in the back bottom car park. Actually moving on this, not just because of the boilers, but the electricity supply and everything. And the kick-off events next Thursday with the suppliers. So this is a real positive. Community diagnostics, certainly good to see it moving forward. Concerned to make sure we do get the right people able to access those services, and that they, you know, those will be part of an ongoing development around diagnostics. We sorely need that, particularly in Kettering. And the last one about the new hospital budget, this was a very sort of technical issue, just making sure that we've got the team to continue working on the new hospital. The fact that the centre has yet to come out with guidance of exactly what's happening, we can but be ready for that. That's the important thing. So that the project team needs to be working, continue to work, so that we're ready.
Thank you. Anything to add?
No, aside from if anybody is new and wants a tour around of where the energy centre is going to be or anything else, happy to do so in the lunch break.
Thank you very much. Next committee then is the group digital, so thank you, Alan.
I think the report sort of stands in its own stead, but just to thank everybody. I won't steal Natasha's thunder because I know it's going to come later on the private board agenda, but thank you all for participating in the board development session last month around digital boards, and the feedback that's all been received and reflected on and continues to be reflected on, and feeds into what we're going to do with digital committee going forwards and the work that Natasha's been doing on that. So thank you for your engagement on that, and I hope that you'll continue that with a bit of feedback later on in the private board session as well. But we hope to resume our formal meetings after a couple more workshop sessions next month, as planned, with our new digital prioritisation to monitor against. Happy to take any questions.
Thank you. Anything you wanted to add, Natasha?
I'll just add from yesterday's NGH board that it was decided that the co-chair will be Annette Whitehouse. So we'll now have a co-chair at NGH, which we're fully supportive of, on those conversations that we had to that point.
Any questions? Okay, thank you. Group transformation. Back to you.
Yes,
Is it?
Say, I did apologise. No, panic then.
Deborah. Okay, if I've missed anything, I can just shout. So our strategic priorities are on the agenda today. So, but at the meeting, there was limited assurance around these, mainly because we felt that the goals didn't have measurable and achievable targets, but I think we'll notice that that's all changed actually today. Notice that there were significant productivity challenges. That's an understatement, isn't it? Whilst we felt that the organisation understood that and understood the challenges, it's really difficult to give substantial assurance if, in fact, we're on moving sand bit because we have industrial action or financial challenges that are just outside our gift at this moment in time. So, so it was noted that we felt everybody understood and there was an evidence base for the programmes in place, but we still couldn't feel fully assured. And as Trevor just said, talking about the strategic development group, we discussed that at the transformation committee, and Becky's team are going to be supporting projects, and they've prioritised those on based on what the output value might be for those projects, and they're going to be reporting each time we have a meeting about the progress on those projects.
Thank you. Anything you wanted to add? Nothing substantial, I don't think. Obviously, we're in that time of year where we're firming up and, you know, getting more concrete plans around a lot of these things so that we can be clearer on where the risk is and how we can mitigate that risk. So that is work ongoing. We'll continue to report that. Okay. Thank you. Any questions?
And just to note that the convener next time will be Andrew.
Thank you.
Great, thank you. Damien, thank you. Finance and Performance Committee.
Yeah, thanks, Dave. So from an operational performance point of view, I think the major assurance we took was how is the trust doing relative to other comparable trusts in the region, and I think the feedback was that we're doing pretty well on most of the metrics. We would be upper quartile if we were benchmarked against other trusts, save for diagnostics, where we are an outlier. And I think there's work going on to improve that situation. From a money point of view, more or less on plan. I think from a KGH point of view, in month and year to date, the substantial part of the finance discussion was really about the FY 23-24 plan. And there has been a resubmission. I think there will be further iterations of the plan. Probably the main challenge we gave back as a committee was around some of the underpinning assumptions. So, for example, there is 4% of efficiencies assumed, and how real is that, and how will we know that they are being delivered? Because in previous years they probably haven't delivered to the extent that we might have liked them to. So there was quite a discussion around that. A couple of other things to highlight: we approved a catering outsourcing procurement that's going on. It's interesting because part of that may include digital meal ordering, which is something that the governors have fed back as something they feel patients would embrace. There was quite some discussion about how you operationalise that, in the sense that moving from paper-based to digital and making sure that nobody gets kind of overlooked from a digital inclusion point of view in making that shift. So it's not just about implementing the technology, it's about the ways of working to make sure that patients who aren't au fait with ordering from a tablet could are helped and assisted in doing that. And finally, we also approved a porter cabin, a number of porter cabins, I think, around the KGH site. I think it was 3 million of capital funding that was awarded under the discharge unit capital fund. It represents quite a major saving to the trust, and is very beneficial in terms of planning for any HIP2 changes that come downstream. And that's probably it.
Thank you. John, did you also add anything?
And just in terms of point of clarity, we're on track in terms of forecast outturn rather than plan. Yes, so not by NHS, but didn't flag any risk to the committee, and not flagging any risk to the board around our ability to deliver that forecast outturn that we've in the papers, public board papers, at 19.4 million. I think it's probably fair to say that the major drivers of our challenge remains or still is pay. We've seen a small drop in our pay spend back to December levels. We're still tracking at numbers slightly lower than the first half of the year, but still significantly higher than we've been pre-pandemic levels. And of course, we'll take those conversations and plans through to the new financial year. And we'll pick up in our private session later on today. So no issues or risk to flag in terms of landing the numbers this year to the committee. And I thought the business case around digital meal ordering, probably important to say that it will not impact on the provision of service on site. This is about us, how we procure food, and is there to ensure that we have better supply chain resilience. And I said this yesterday at Northampton, in English that means we're able to buy the right food and there aren't gaps, and we're able to buy food that meet NHS food standards around kind of red tractor for meats, etc. So I think that's important in terms of supply chain resilience, and important to say that our patients, other than, as Damien said, the further work to do around digital meal ordering, which will provide more convenience for our patients, i.e. they can order food sooner or closer to the time that will get delivered. And secondly, help us deliver a reduction in waste, which of course is a key challenge for us, and will help in terms of our net zero waste ambitions. So I think that was quite positive, a bit of work to do still there on the rollout.
And if I may just make a couple of points as well in terms of performance. So in terms of diagnostics, I think at the last board we did raise, we were particularly concerned, as Damien has alluded to. We do actually have a plan now, so the CDCs are coming online, and in addition to that, we've secured some more funding as part of the ERF, which enables us to commission more capacity, particularly for MRI and for ultrasound, which means that by March 24 we will be able to hit the national aspiration, which is 85% of patients receiving their diagnostics within 6 weeks. Clearly, we still have further to go, but it's good news that we've received additional money to support that. Given that we are just, I suppose, come out of the winter months, just to mention urgent care, it continues to be and has been the last couple of months very busy. We continue to operate over 100% of our occupancy. We are busy planning for next year, even though we're not only just coming out of winter. But I think it's important to note that the amazing work that urgent care continue to do despite the ongoing pressures. Our attendances are still high, yet they still manage to turn the ambulances over within the 60 minutes, which is what we were asked to do. Even during the strike days, they managed to deliver that, which I think is to be noted. So thank you. Any questions for performance? Okay.
Just a comment.
Yep.
Ian, thanks for the update about the catering provider, because when I read this, I was thinking the cooks.
That's why I made the comment.
And actually these notes suggest that at the moment, and so it's really important, I think, that when that these minutes really reflect it's the food supplier, because we have a great team on site. They will be really pleased because they want to provide fresh food provided by a really good supplier. And when I spoke to them recently, they were also very keen on how they would reduce waste. And of course, you've just described something that I think they really would welcome. So thank you. Please.
Yeah, it's really going back to the doctor strikes and the impact on elective performance. Could you just clarify where we've ended the year in terms of the number of long waits? And actually, just to give us a handle on how many operations have we actually cancelled in the last 4-day strike and the one coming up? Because I think that gives the public a sense of the impact on our trust.
So during the last strike, we cancelled about 2,500 outpatients and 400 elective procedures. This time we're just still tilting those numbers up because obviously we've still been, we've only really been instructed, I guess, or asked to cancel patients from Wednesday. I think it's fair to say that NHS England was still hoping that we would not be having the strike, and therefore we were asked to hold back in terms of cancellations, which, as you can imagine, is tricky for the staff and tricky for the patients. So yeah, it's huge numbers, and obviously we're expecting similar numbers for this strike as well. Remind me of your first question. I've forgotten that.
How many long waiters?
Thank you. Yes, okay, thank you. So the national aspiration, at the moment we're not talking about 18 weeks in RCT. We have national aspirations, I guess, rather than targets, and it's about how we reduce those wait times. As you know, we've always been pretty good. We do have one patient at the moment that is over 78 weeks. The patient does have a date, and this is a patient choice. So that is the only patient, and that patient is one of our legacy Leicester patients. We have roughly about 300 patients over 52 weeks. The next aspiration is get it down to 68 by March 24. We are well on track to deliver that. We would exceed that. So it is about just chipping away in a logical way. But we are still nationally in a much better position than most organisations.
Can I just go back to the NHS advice?
Yeah.
I have to say, my advice would be to ignore it. I know they are our regulators, but they're not thinking of patients. As a patient, having your operational procedure cancelled and you're sitting in the car park at 6:30 a.m. is totally unacceptable.
Just to
It
clarify,
merits legal action in my
just to clarify, we're not cancelling on the day, we're not bringing them to the hospital, absolutely. But what that means though, Chris, is that, so we started to cancelling yesterday or Tuesday, so people are getting notice, but it's still very short notice agreed, but we're absolutely not on any occasion have we cancelled people on the day, it's always preemptive.
Great, thank you.
Good, sorry, can I just go back on that one, because I think it's important what you told me earlier. Clearly, we've got a bank holiday weekend where our admin staff will not be working over that weekend. So it is important that we let the patients know as soon as possible. But this may mean that we, the hand of NHSE might come down and say, you should have not done this at this stage. Totally agree with what you say, Chris. The patients need to know as soon as possible if procedures are being cancelled.
There are occasions in my professional lifetime when the advice from NHSE is anti-clinical, anti-patient and anti the service. I have to say, we should just ignore it and take whatever consequences. I'm afraid they cannot send you to prison for ignoring their advice. You can be sent to prison for damaging patients, and I think that is a really important distinction. I'm sorry to be so forceful about it, but it really irritates beyond belief their incompetence.
John, what are the implications for the hospital for missing the financial plan to the extent that we have done this year?
So in year none. So we agreed with the National Chief Finance Officer, so a guy called Julian Kelly, back in December, what the system financial delivery for this year would look like. And the forecast outturn that I've briefed on and said will hit was part of that agreed number. So assuming we deliver, I don't quite have the final numbers yet, because we haven't closed the accounts, but assuming we deliver individually and then collectively as a system, we will have met the requirement on us from an NHS England point of view. The big challenge we have is we're still running a very, very significant deficit, and we carry that forward to the new financial year. And that will leave us in basically a replay of the exact same conversation we had this year, which is the ask on us as a system is to deliver break even. And we are a considerable way away from doing that, and suggest we pick up that detail in the private session so I can brief as to where we've got to. So on the in-year position, so 22-23, we will deliver on what we have been requested to deliver and have agreed with NHS England we will deliver. Clearly that has quite large implications for the ask on us, because essentially the ask gets reset as we move into 23-24, and given that we are so far away from that ask, the challenge is considerable.
So we carry forward that deficit.
Well, we're running a deficit month on month, and if we do nothing to correct that deficit, it will just run on.
Yeah.
And yeah, I can talk through the kind of moving parts in terms of the planning for 23-24 in detail. In the private session, the planning round, I think it's fair to say, has not concluded yet. It is not concluded nationally, and there is at least another kind of turn of the handle. We submitted a draft plan at the back end of March. The collective national position is that those plans do not meet national expectations or ask, and therefore we're going to need to work through how we might be able to improve that, including what implications and trade-offs we would need to make individually and as an ICB to be able to kind of balance those competing priorities.
Yeah.
There is the spectre of enhanced scrutiny from NHSE. I don't know how that manifests itself, but you have mentioned that as a consequence of missing plan.
Agreed. So this year, so 22-23, we were under significant enhanced scrutiny. The reason that myself and
what does that mean?
That means two things. It means, one, we are asked to account and our numbers are reviewed, challenged, etc. by our NHSE national colleagues. We were in the point where we had some of the largest deficits in the country as a system. And therefore we get called to account by the National Chief Finance Officer. That happened in December 22. And from an approvals authority to basically conduct business, we are unable to now approve any level of new investment above £50,000 without either our regional, without our RCB agreeing to it, or our regional NHS England team agreeing to it. So basically, we have no authority in day-to-day terms to commit any new expenditure.
So that is a direct implication.
That is a direct implication, and those rules came out, I think November, December last calendar year. It took a while to come out, but those are now in place. We have said we are not going to deliver a break-even plan, and therefore a set of kind of enhanced oversight type things are now in place. So we're not allowed to approve anything over 50k. We need to ask for approval to do so. Specific controls around temporary staffing and agency, and a whole load of regulatory oversight and intervention that will prevent us from being able to make local decisions, and therefore takes longer.
Not ideal.
Not ideal, but clearly the challenge on us is to do the best we can, and we are, as a hospital, an outlier in the wrong sense in terms of scale of deficit.
Okay, thank you.
Okay, thank you. So next is group people.
So we're going to talk strategic priorities later, but we as a group reviewed the priorities, and I felt that the one that had been agreed pre-pandemic didn't talk to staff, the metric, and also the metrics that sit underneath that. So you'll notice later that we're aspiring to things that matter to staff. So whether they want to be treated here or whether they would want to recommend friends to come and work here. And we'll talk about that more in detail later. We looked, other area of note was the safer staffing report. We have concerns about the roster not being used effectively, and also our understanding about some of the leave that we're experiencing. So parental leave, for example, sickness absence is actually not terrible at the moment, but parental leave was quite high, and we don't really understand that. So Jane is going back to basics on the roster, isn't it, really? So we had fairly limited assurance about our ability to manage that at the moment, and certainly that impact is felt by John when we're asking for banking agency staff to come in. And we did express thanks to our HR business colleagues for their engagement with the not the regulatory bodies, the bodies representing staff during the industrial action, and also the colleagues that supported them in putting plans in place, because we've managed to maintain a workforce during that period and a safe workforce, and so we are really grateful to them. Thank you.
The only other thing to say probably is that we had a detailed conversation around the staff survey and the findings from that survey, and in particular, of course, what we're doing as a result of it, and the committee determined reasonable assurance around those plans.
On the staff survey, which obviously was a bit disappointing, to say the least, is there an action plan in terms of what we do about that?
Yes, so I've got a more detailed paper later this morning, but essentially both the SLTs in each organisation have done some, they spent some time looking at a deep dive into what the survey tells them into detail, and that deep dive approach is being shared out across the organisation. But then we're linking that in with our culture work in terms of coming up then with our priorities for discovery in terms of the culture piece. So I will come on to that later this morning.
Okay, thank you.
Thank you.
Sorry, that's all right. I don't know if it was raised in the meeting, so it may be more appropriate to discuss it later. Please tell me if so. But can you just sort of give us an update on where we are on the temporary staff costings? Because the IGR tables suggest it's not improving yet, if you like, in terms of that overall position. But equally, we hear that the controls have been strengthened. It'd just be good to hear where I think we are on that at the moment.
I'll start. So I think we have got the controls in place that we've discussed here before. There are fundamental challenges though in terms of the growth in staff over the last 2 or 3 years that we've seen, and we've all heard about that 10% figure before, haven't we? We will talk this afternoon about the workforce challenge, but in my view, and I think John shares that view, this is about fundamentally looking again at the areas of our workforce that have had the largest growth, rather than what we do in the vacancy control panel, which is relevant and important, but is looking at individual posts as they come through. This needs a more holistic look at patient pathways and how teams work.
Yeah. Okay, thank you.
Yeah, I mean, I think Alice, the answer isn't either or, it's both. And we have had some quite reasonable and challenging conversations about why we're looking to recruit to certain roles in some areas. And I guess I'll probably take from a positive view that the vast majority of roles that have come to the panel that have been well explained. So we're on a journey, right? And the conversations we're having in early January, is that long ago? I think it was, were, do you understand your movements in workforce? And the vast majority of answers were no. So we probably should understand that, shouldn't we, given the quite large increases, certainly in some areas of the hospital. So we are in a far better place to kind of understand that now, and that's slightly processy. We are also now finding that we're able to get under the skin of some of those bigger challenges. So, for example, we had a conversation about a recruitment to a junior medical role within emergency medicine the other month, and we know that we've seen quite a significant increase in those roles. However, what we hadn't done is kind of joined the dots. I think John had literally just, I think he's about a week in to the role, had a conversation about, okay, so how are we going to link the medical director role to our clinical director, to our operational manager, to actually work through what's happened, where and why, and what we might change. And those conversations would have happened anyway, but that forum kind of gave us a little bit of an impetus to do that earlier than we might otherwise have done it. I am not expecting something like a vacancy control panel to mean that we suddenly have a nosedive in the amount of roles that we appoint. I'm expecting, and from my experience working elsewhere, we'll have a level of challenge on probably 10 or 20% of them. What I have been told, and it's anecdote, is that there are some roles, because they're now being reviewed at a divisional level before they come to an executive panel, there are roles that simply just don't go through the process. I think that will take a while, and the timeline that I've kind of given to people, is this really worth the effort? I think it's probably going to take a good 6 months so that we can get into that process.
And on the temporary side, just to come back, the temporary staff issue, is that, how does that link into the controls you've talked about?
So the controls that I'm talking about are predominantly around long line, in English I mean long-term agency staff. We have a process, a policy within KGH that you are not allowed to have someone in that role for more than 12 weeks. And we review those on a cyclical basis so that they are evidenced and demonstrated. I think it's fair to say we've got further work to do, and Jane has been heavily engaged around from a ward nursing point of view on how does that align with safer staffing, how does that align with the work that we got ongoing around the safer nursing care tool, and therefore wider assurance. So I think it's fair to say that's work in progress. We've got far more of those building blocks in place. I sit back and kind of go from a CFO, it means we're now going to have to make some really difficult decisions, and we haven't quite made those yet.
Jo, may I follow up with just one, just to really reassure the board that we are working and our rosters are planned against safer nursing care tools for all of our registered staff and unregistered healthcare staff, so that we are meeting all of our national requirements around that. We have very robust processes around understanding our daily staffing and where we might need to move staff, etc., to ensure our clinical care is safe.
So following on from that, the challenge is that we still have, you're having to move people around, aren't you? The roster is not always being used as effectively as Jane would prefer it to be used. And so healthcare assistants, particularly for us, are a challenge, and that then you're then bringing in bank staff if you're not fully covered. So there's so many challenges on so many different levels at the moment, but everybody is looking at trying to resolve it.
Thank you. Okay, and then quality committee. Thank you, Chris.
Thank you. You've got 4 pages of reports, so 2 meetings, 24th of February and the 31st of March. I'm not going to go through all of them, you'll be pleased to know, but I just mentioned some highlights. So the first thing is fire compartmentation work here has been completed, which is an important substantial assurance given the recent incident at Northampton. Second thing I wanted to mention was that in the organisation of the agenda of the committee, the subgroups that report to the Quality Committee in Common have come right to the top of the agenda rather than being at the tail end, because the reports from those subgroups are the foundations on which this committee rests. And so we have moved from a position from that we had an incomplete list of subgroups. We now have a complete list, and we are now starting to get monthly reports from them. So that's an improving position there. So moving on, I won't mention maternity because that's going to come up in a few moments. In February, we had the first joint report on urgent and emergency care. And the second one came in March, and it was a really, really good comparative report. And I say thank you to Faye and to Palmer for presenting that report, because it was actually a really good example of the sorts of report that should be coming to the committee so that we can compare and contrast and learn from. Moving on again, we went through the committee's terms of reference. We looked at the committee evaluation, and I will leave others to speak as to whether or not they think the committee is working well. But I would say that, wouldn't I? We commented on some issues with the IGR, particularly where the 2 organisations have been unable to agree the same accounting method and the same definitions for certain things, which is not a digital issue, it's actually a clinical or a administrative counting issue that needs to be sorted. I think the final thing that I'll mention is that we had the first report on clinical collaboration updates from cardiology and from head and neck, which was really great to receive these reports. But we only got limited assurance from them because there was actually no metrics about what they'd achieved over the previous months, year. So we're looking for further clinical collaboration reports, and we're now going to have one a month at each meeting for a different service going forward. So I think those are the things I wanted to raise, but happy to take any questions.
Is that point on lack of metrics being addressed?
It is being addressed. It is proving more difficult in certain fields than in others. For example, it took, I think, probably 6 to 9 months to agree how we count complaints in the 2 organisations. Yes, John.
Yeah, just 2 points to add to Chris's. One around the clinical collaboration. I think the real reassurance was how joining 2 services together into joint leadership has done some longer term stability issues. So for cardiology, they've now got accreditation, they're looking to appoint, and it's a more attractive offer because consultants can provide a full scope of services. And so that was seen as important. We haven't got the clinical metrics. So if you remember, NGH doesn't provide the level of response for heart attacks that KGH does by a significant amount. So we haven't got those metrics, and we've really pushed them to deliver those metrics in this year so we can see the impact on individual patients. But it was reassuring in that actually the infrastructure was getting more robust. So actually the longer term feature of that service was seen as more reassured. And the second one was around metrics. So we had, as Chris said, a discussion about where there was disagreement about metrics, but we also, and I'm going to put Alice and Natasha on the spot, a view that actually where metrics had been agreed, it was now down to a data issue of data warehouses were being constructed in a different way. So it was impossible to gather the data in the same way. So I'm not expecting you to give me a timetable, but has that issue been raised with the Digital Committee or with yourself as the exec lead for digital? And have you got a plan to align those data warehouses?
This is the same way between the two sites, between the two trusts.
Yes.
It hasn't specifically been raised to the Digital Committee, but I'll let Natasha answer.
Thanks, Emma. So a couple of things I'm going to bring in here. One is that we're at the time now when, leading into the conversation later on about strategic priorities that have been decided, acknowledging that actually a few committees have come out and said we need to make sure that the metrics we have in the IGR reflect those priorities and also reflect what the committees are discussing. So actually we need to do a bit of, I'm going to say, triangulation between what we currently have and what we need in the future. And actually there are sessions in the diary to discuss some of that. In terms of the group data warehouse, that is a key focus for us, and actually there has been some groundwork underway and has been completed on getting that group data warehouse constructed. I would describe it as being, you know, the foundations are being built alongside what we're currently doing. So we haven't been able to switch yet. There's still quite a lot of work to do to get there. But from a health intelligence point of view, that has been a key priority to date. So in terms of your question, yes, aware of the overarching strategic need here. I would say the specifics that you're probably referring to on each report, I would hope will come out in the discussion in that workshop that I'm referring to around what we need for each committee and on what data feeds into those reports.
Okay, could we have a feedback then to the policy committee about that? Because it seems as though we're being given two reasons for non-progression of the IGR metrics, and it would be good to pinpoint the contribution of each of those reasons to the non-progression. Sorry, that's a really.
I think there's there's also probably a slightly different answer between the IGR level metrics and those you're talking about in the collaboration areas, Liz, because I think for the collaboration areas, I know we're going to talk about that this afternoon, but I think we need to find a way to support the collaboration areas, particularly on digital, that's workable, that hasn't probably been cracked to date.
Just come back with one more thing. The head and neck report, which was very, very helpful, actually raised the issue about the complex management arrangements of that service. And we thought that it is worth mentioning that it's a service that's in two trusts, two divisions, 4 committees it reports to, and where does the decision get made? So reflecting on that, if we're going to go forward with further clinical collaboration, we really do need to start thinking about single management arrangements for these services. For example, as I've seen elsewhere, that service is given entirely to a organisation to be provided in that organisation and others. Everybody understands that the management of that is in that first organisation. So that's helpful in managing the health service. So we really do need to start thinking about those circumstances going forward.
Yeah, so absolutely, totally agree with you. So the medical directors and myself have been working on a draft approach and a framework for target operating models for the different services, because one size doesn't fit all for each of the services. Obviously, some, that example, that would absolutely suit, others a different arrangement would suit better. But we have started working on what does that draft framework look like. That will come to Quality and Safety Committee as appropriate.
Correct. Yeah. Thanks. Yeah. Just picking up on this collaboration point, because I think we need to be, and this came out of the SABRE report, I think we need to be clear with the people on what we mean by collaboration, because there's still a lot of discussion about that. And as Polly says, there's at least 3 different ways that that could be done. That feeds into what you just been saying. Well, if we can get that clarity, that's going to be a real step in the right direction. And there's a whole load of other underpinning stuff that again came up in the Siegler report that we just need to get right.
Okay, thank you. Conscious didn't ask John or Jane if there's anything to add. If
Sorry, yeah, I was just going to say, you said it would go to quality and safety, but I think transformation would be looking at these changes to next, for example, wouldn't you? Because we want to be clear there are no unintended consequences, and I've seen other things come through where I'm concerned.
Can I suggest we pick that up?
Yeah.
This afternoon?
Okay.
I think there's a number of complexities here that
Okay.
we need to pick up. That's not because we necessarily need to do it in private session, but I'll just give you links in to some of this afternoon's discussions.
Okay, unless there's anything else on quality committee?
Just very briefly, the opportunity of learning from each other from this committee, I think can't be underestimated. So just picking up on something that Chris had said.
Yeah, and as a committee, we were unanimous that actually we wanted the quality joint committee to continue.
John?
Yeah, two things. First, in terms of the mortality data, that's all our indicators, not just the SME, which is the main indicator. It's on the IGR, but the HSMR and the SMR are now as expected for Kerry, which is good. And the SME's been in range for about, I think it's about 9 months now. Just wanted to make sure we spotted that. And then picking up on the point about the IGR, I think it's a fair bit more work to be done on the IGR, and it's just, for example, the mortality indices don't lend themselves to SPC charts. Yeah. So we just need to work out how we make sure that we see that fairly clearly, and whether we need to add in all the mortality indicators. And one of them I think we should be tracking is crew mortality, which does lend itself to SPC charts. So there's some complexity around there that we need to work through outside the meetings. But with those meetings with I've forgotten, is it Richard Innes and Mike Innes, sorry, and his team. There's meetings in place to do that work.
Thank you very much. Okay, so just 2 points for noting. Audit committee hasn't met since the last board, but I think because of
because meeting in April.
Yeah. Elective Care Collaborative hasn't met since the last board. However, there is a meeting scheduled in May and meetings onwards. So thank you very much.
Just one point at the end of that, not an open question, but I do think that the requirement to say limited reasonable assurance, etc., is focusing the committees in terms of the papers they're getting and some of those discussions. Limited assurance actually is in many cases a good thing, because it's actually saying what is it that we need in this committee, rather than that being a criticism. It's about how do we make sure the committees are functioning properly. But it can be that actually there is limited assurance. We have defined what it is, and there is limited assurance, so that we can all have that.
Sorry, Trevor, can I just make a really quick general comment on the IGR, which doesn't apply to any particular committee. There are still a number of places where we're showing no target on some of these SPC charts, and I don't really understand why we're this far in and we've still not got a target on some of these things. And it makes reading it very difficult.
There are a number of things like that. I think there's a whole separate conversation about IGR that we need to go into. At that point, can we move on to maternity reports? We'll take up the report and welcome Lara.
Thank you very much. So many of you remember that I was here back in November 2022, following the publication of the Reading the Signals report in October 2022, which was the independent review led by Dr. Bill Kirkup into the East Kent maternity services. And this independent review followed the already independent review completed by Donna Ogden in the Telford and Shrewsbury maternity services. So what this review identified is there were out of 65 in-depth cases reviewed where a baby had died, there was a potential for 45 of those babies to have a possible different outcome. So therefore, the recommendations and themes made around maternity services in East Kent were made by Dr. Claire Cup. The key themes he identified concerning were team working, professionalism, compassion, an absent learning culture, and also not hearing the voices of their patients. He then linked these findings into 4 key themes, them being monitoring safety and performance, standards of clinical behaviour, flawed team working and organisational behaviour. And you'll see in Appendix 1 of your papers that we have undertaken assessment against those 4 areas within Kettering to enable us to ensure ourselves or assure ourselves that we are not an East Kent maternity service, and I can provide that assurance that we are not. Following on from that, we have recognised some further work to do. One of them is around a culture survey. So whilst I can sit in front of you today and say that our team at Kettering does not represent that team flawed work in East Kent, whereby our midwives and our obstetricians work incredibly well together. We train together, we learn together, we deliver care together, and that includes listening to the patient voice. What a culture survey will enable us to do is really test that. So as part of the NHS England offer to all maternity services, they have offered leadership development for the quad leadership within maternity neonatal care. That will include the clinical director for obstetrics, the head of midwifery, the lead clinician for neonatal care, and also the operational manager. So NHS England is delivering this over the next couple of years, and actually Kettering is already included in that programme of work. Following that programme work and completion, which will happen towards the end of this year, NHS England will then offer us to take place in part of the SCORE survey, whereby you have to have a 65% response rate from everybody, every profession working in maternity services. That will include midwives, obstetrician, neonatal nurses, neonatal doctors, theatre staff and anaesthetists, and it will really deep dive into any cultural issues that you have. So we, of course, that is an offer from NHS England to come into that survey, and we, of course, will accept that offer here at Kettering. The other area that we feel that we need to maybe enhance is our listening to the voice of patients within everything that we do within maternity services. That is certainly a key message from the Maternity Neonatal Summit that I attended a couple of weeks ago in Leeds, that was led by NHS England, and that means true collaboration. So at the heart of everything we do, we hear the voice of the patient. So we are also looking, which will be externally funded by the system through the Maternity Transformation Fund money, a patient experience midwife who is likely to be a midwife who will work with our service users to bring that voice into everything that we do. And we've also at the moment have an interim, a seconded post that we hope to secure that further funding to secure that post in the future, of a lead professional midwifery advocate who is certainly providing support to our staff around psychological safety, and we're already seeing an impact on our retention in midwifery from that role. So following on from Holden and from East Kent, so Bill Kirkup's report, NHS England committed to delivering a plan for maternity services over the next 3 years. That plan was only published on the 31st of March. And again, it takes in some of the recommendations, but not all the recommendations from both reports. The plan is again keyed around 4 theme areas. One is listening to and working with families with compassion. The next being growing, retaining and supporting our workforce. The third being developing and sustaining a culture of safety and learning. And the fourth being standards and structures that underpin safer, more personalised and equitable care for our patients. And that lists responsibilities not only for trusts, for organisations, but also for systems and NHS England itself. Now, there will be a requirement to update board around that whole plan, which I'll be back to do. But just to give some really key features about that is in relation to retaining support in our staff, where many organisations will struggle. is around the support to fund your establishment, your midwifery establishment, as suggested by Birth Rate Plus, which is the national tool. And at Kettering, we made a commitment to that back in 2021, January 2021, we gave board support for that, and we've had that. And yes, we have vacancies against that, but we now have a growing number of midwives coming in from qualification from the university into the service. And we hope to can fill all of our midwifery vacancies by the end of this year. So we'll be ahead of the 3-year plan in that sense. The second around developing and sustaining a culture of safety and learning support. We recently had a visit from the system in relation to a Never event that happened in maternity services going back now a couple of years ago, and it was around wrong route medication, and they were overwhelmed by actually how they thought that we'd already implemented a PSERF model within maternity services and recommended that we share that out organisationally, which we plan to do with our patient safety team. And the next one about standardised care is about implementing a early recognition scoring tool for deteriorating mothers and babies. That being similar in nursing, you have a warning score. In maternity, we also have a warning score to identify women who are deteriorating, and we also have one of those obviously in our neonatal services, and we already use those within both of our services, and will adopt the national tools when they are released. The last thing that I want to mention is again the support that the organisation has provided to develop leadership training in maternity services, specifically to maternity services. This was definitely a key theme that came out of the Kirkup and the Ockenden reports. So not only will the Quad receive that support from NHS England, we've commissioned the King's Fund to come and deliver that leadership training to all of our Band 7 midwives and our matrons and our heads of midwifery and head of nursing for paediatrics, and that has already started that work and will be completed in September this year. Okay.
Jane, have you got anything to add?
I don't think there is any more to answer, Madam Chair. The only thing I would say is just my few months in post, this team have had two really incredibly complex, unusual cases that spring to mind, and they've been outstanding in the way they've really tailored care to those individuals. So should be incredibly proud.
Any questions?
Just to add, so what Mara summarised is probably the culmination of quite innovative, quite courageous approaches. So when I did the cross fingers for a full midwife establishment, it wasn't that I don't think we put things in place. It's as soon as you start recruiting, people go, actually I'm about to retire or I'm about to go on maternity leave myself. You know, Mara's team have put into place different ways of recruiting. So students are made well aware that actually if they want to come back, they can come back, and it's made an easy process. And actually we invested in midwifery student numbers several years ago, so that's really coming to fruition. So I think what this service shows you is when you take a longer term view, you can start seeing the benefits, and I have substantial assurance that we have got a safe and high quality midwifery service.
So great plan. The bit of a concern around kind of a national reaction to, if there is a problem, let's add another person in the mix to fix it. And that type of approach, partly from a money point of view, it will be one-off money. We'll have to resolve it longer term. We'll need to work through that. But I guess from my point of view is, can we look at how those supports and interventions might be tailored or kind of expanded across the hospital? Because clearly it's not just midwifery or that area of the hospital that might require that, and therefore we'll have strength in numbers and kind of strength in expertise, won't we?
Sure, I think in its infancy at Kettering General is the professional nurse advocate, and I think there's a lot to learn from a nursing perspective, and we'll do that work. That role is very much in its infancy nationally as well, around the role of the professional midwifery advocate in retaining staff, providing them with restoratory supervision, psychological safety, away from their management team away from their line manager. And yeah, I mean, one of the first things I said to the PMA, Professional Midwifery Advocate Lead, when she came into post was, I need you to demonstrate the value of your post at the end of this 12 months. So if I don't see an improvement in retention, then the post won't be supported moving forward. And I think that's certainly given her the oomph to do what she needs to do.
Thank you.
Thank you, Mara. Echoing what John said, there's transferable issues here, things that we could share across this organisation, and I would hope that we would do that, that when you feel comfortable and confident that you actually start to share this with other teams. On another note, in the actual paper that the covering paper, and I don't think this represents this organisation, nor do I think it represents your service. Under risk and assurance, it goes, compromises our trust strategic objectives and may result in increased planning to poor patient outcomes. I would just argue that that prioritisation of order there doesn't represent the culture we have here, and I would just ask that that was changed.
Of course.
Yes, thank you.
I'm not seeing any other questions. You've sort of dealt with everything up front. I know, you know, from my own position, I've also seen one of those other temporary posts perform last Friday in a safeguarding group talking about addiction and substance misuse. And I think there are lots of themes, and picking up John's point, is how do we make this embedded? So not just having specialists for this, specialists for that, but actually how do we make sure it becomes part of everybody's work in practice, rather than just having specialists dealing with it. Specialists quite often in the right fulcrum point to start that conversation, but it's how do we get that, you know, across the board. And my ongoing concern for you and your staff is great bringing in all these new staff, and I'm sure they will be great going forward, but supporting them actually, and the dynamic change that makes in terms of the team. We've got a lot of new starters, can't be underestimated. And I'm sure you understand that.
Yeah.
But actually being aware that we need to be focused on that as an issue and a risk in itself.
Yeah. So just on that, if I may, so we have invested, and again through system money that was put in short term, in the preceptorship development of our new Band 5 midwives. So we now have a full-time preceptor midwife that's supporting them, and that's because historically we may have had only 3 or 4 midwives start at a time, and now we're seeing 10, 11, 12 midwives start at any one time. We've also, through external money, been able to support a couple of our retired midwives, really experienced midwives that don't want a permanent contract anymore, want the flexibility of being still a bank workers, to come and work clinically with our new starters. And again, they're not picking up full shifts, they're coming in for part of the shift with that new starter, but given the support over those few hours that they're here, it suits both the retired midwife, but it also suits the newly qualified midwife.
I think going forward, Chair, we've had lots of discussions about how we properly support, retain and grow these midwives into really high quality professionals. I think going forward, a bit of work we still need to do is the people we've currently got in those band 6, 7 roles. How do we now develop those to hang on to them? But I mean, Mara's got plans. Can't do everything in straight away, but there's certainly plans, and we're building on some of those.
Well, thank you very much.
Thank you.
I think we'll see you later on.
Yes.
Today.
Yeah, thank you.
Thank you. We're going to break now for, we're going to try and make it 8 or 9 minutes rather than 10 minutes, otherwise we'll be chipping away at the next session. Break. Thank you. Welcome, Karen.
Yep, thank you. So thank you, everyone. I'm here with this paper today, presenting it to board, the paper around strategic priorities. So I wanted to I'll take the paper as read, but I'll just set out some of the key points, and then I'll come to the chairs for each of the relevant committees to update, in particular, on your discussion and recommendation for approval for each of those the priorities that sit within your under the remit of each of those committees. So as colleagues will be aware, as part of the integrated business planning process, every year we would ordinarily be looking at reviewing our strategic priorities, understanding kind of where we've got to so far and what we need to do for the forthcoming year, and then build those into the plans. So we have done that as part of, and you'll recall that as part of the dedicated excellence strategy, we set out the 5 strategic priorities. We agreed that back in January that those were still current, but that we needed to review the goals and the metrics that we set out, and then in particular look at what we're going to do not only for the next 3 to 5 years, which actually we've clarified as for the next 4 years, but then also very specifically what are we going to focus on for this coming year 23-24, and then build that into our plans. So that's what we've done. The paper does set out the review of the metrics that we had originally set out. And you'll note that we haven't necessarily made progress against all of those. There's a number of reasons for that, but we have made progress in other areas. Key is the change that we have recommended as part of the longer term 4-year goals. And I would like to say that, thank you to everyone who's been involved in this. This has been very much a combined effort of all the executives and non-executives, and Becky and the team, for everyone who's been working on this. So thank you to everyone. But each of those committees agreed the changes to the longer term goals. We've agreed that they're fixed. We recommend there for 4 years. And they're set out on slides as the summary UHN goals and success measures slides. And then within the pack, you can then see the detail of what we're focusing on specifically for 23-24. Those will then need further workup as we work on the detailed programmes which sit within those. Timescales, leads, etc. need to be the next stage. Will be developing those so that we can really sort of work to develop those. In terms of next steps, before I come on to each of the committee members chairs to talk specifically around their priorities. The next steps then will be around, once we've approved these, is communicating them, making sure we've got them out across the organisation, really embedded in the organisations, and then really focusing on tracking delivery, not only of each of those objectives for the coming year, but also are they actually really impacting on the 4-year goals, and if not, why not, and therefore what would we need to do to review that. And there'll be quarterly reporting through the committees. So I'll pause there and come to each. So for people, I don't know if Deborah, if you want to update where we've got to in the people committee.
After a lot of discussion, as I said earlier, we wanted these measures to matter to people on the ground. And yes, we're driven by the staff survey, and yes, we were disappointed, but we need to move forward. So we wanted to look at advocacy and our equality and diversity. We also reflected on what we'd achieved in the past year, and you can see that on page 6 of this report. But moving forward, we want people to recommend it as a place to work. If they recommend it as a place to work, they're happier here themselves, and happy for a friend or family to be treated here. And actually that reflects on safety and quality, because if you want that, people feel safe. And improvement in the specific diversity measures. And Alice, in response to your question about goals, this felt a really uncomfortable one. How do we put a goal on it? It should be that everybody feels welcome. We have to be realistic about where we are now and where we want to be. So putting a target in here felt a little uncomfortable, but we did it. There are goals underneath this that will contribute. So developing our people, and listening to Mara earlier, I think there's scope to do that across the organisation, but it will rely on other elements such as appraisal. Improving the health and well-being of our staff. We actually have quite a strong health and well-being offer to staff, but that doesn't mean that we can't keep reviewing it and reflecting and improving it. Our dedicated to excellence cultural change is really important. Stumbling block at the moment is the recruitment of the ambassadors, but we're trying to work around that, and see if we can utilise other staff groups to help. So John, I've suggested that maybe we approach some medics about their leadership development and involving them, but we'll see where we get to. Harmonising policies from a group perspective is really important. It enables people to work across this county, and we should want that. And reducing our reliance on temporary staff is really key. If we can engage with people to make them feel welcome here, if we can get people to feel happy at work, actually we will rely less on them because they will encourage people to come and work here substantively. And the chances are we will get less absence for stress and ill health. And I'll leave it there for questions.
Any questions on the people priorities?
Just a really small one, Trevor. I appreciate you have to let some things go if you bring new things in, so this will sound a bit of a picky question, but we're removing any sort of measure against the pulse survey, and I guess it's a more of a general question. But are we finding that the pulse survey is proving useful or not? And if not, are we planning to change it?
So in answer to your question, I don't think we have really got to grips with the pulse survey yet. In fact, I had a meeting this morning with the team. So one thing that we are doing as part of the culture work is setting out our engagement strategy for that work. And I think aligned to that needs to be, how are we going to use the pulse each quarter to ask relevant questions that feed into the culture work and where we're at in that 3 to 5 year plan in terms of changing the culture.
So it's very much staying, it's more
yes,
steering it.
Yes.
Andrew.
It's great to see so many references to culture through the quiz papers. Because from my background, I mean, culture is so important. It covers every part of the organisation. Are we in a position at this stage to kind of describe the culture that we aspire to?
So in terms of the people plan sets out the strategic direction that we want to go into and describes that culture. So in terms of have we got something written down? Yes, we do. Each organisation in the SLT recently has spent some time thinking about what the staff survey tells us, but then also thinking about what kind of place do we want to have and what do we therefore need to focus on. So I think each organisation, the two organisations were in slightly different places. So for example, race is a significant issue here, more significant issue here than at Northampton. Still a problem at Northampton, but it's more pronounced here. So I think the focus on some of those areas will be slightly nuanced in each hospital, which is why they've taken some time to think about what are the priorities. I don't know if the local SLT want to add anything to that.
Have we got a plan as to how to deliver it?
Yes, so the next step is, so we're having a three-phase plan. So the first bit was understand the survey. The second bit was think about the priorities. And the third bit, which is planned in for the next couple of weeks, is to come up with the plan. So how are we going to the discovery phase? What's that going to look like, to Deborah's point around how are we going to use the ambassadors? Do we want ambassadors? What type of staff groups do we want to involve? Will that be focused in certain areas of the hospital? So for example, we're doing a cultural audit in ED here at the moment. Do we want to really focus in on ED and do some focused work there? And then we'll be bringing that to the May board development session in terms of here is the plan, this is what we're going to do.
It's so important that we have full alignment on that, isn't it? The senior team are shoulder to shoulder.
Absolutely. Yeah, it's not just a HR.
Not at all. Not at all.
Just hesitating slightly because we're going to come on to the staff survey, so I don't want to overlap too
leading
much.
me down that route.
That's my niece.
Yeah, can we then demonstrate to others how that cultural piece of work links to our core values, which are plastered in, because it's really important for people at the coalface actually working with patients to see how the culture reflects the values that actually are pinned up around the hospital.
A lot of the work that we will be doing, Lise, is very much focused on embedding those, because at the moment they're on the wall really, aren't they? So for example, on a very practical level, my team at the moment is reviewing policies in the workforce arena and the values. How do we live our values through this policy? What features of this policy can really embed those values? And one of the things that we'll be doing as part of the discovery work is some focus groups with colleagues in their area of work in terms of what do these values mean to you as an ODP? What do they mean to you as a member of the housekeeping team? To really bring that to life.
Right, I think we need to move on from people.
Thank you. The next two sit within the quality committee, so patient and quality. So Chris, over to you.
Yes, I think the first thing to say is, although these are the quality indicators, so much of the priorities in people and in systems and partnership are actually the complete indicators of quality. For example, diagnostics within 6 weeks is in systems and partnerships, but is actually fundamental to patient quality. So although these are listed as the quality objectives, it's actually the whole of the menu relates to quality. And I think I just draw your attention to a couple of them. The aspiration to no avoidable harm is a very, very high objective. I'm not sure it's attainable, but it is certainly worth aspiring to it. And the second thing I'd say is the mortality indices as a whole, as John described earlier, is a really important indicator of where we are. So I think for me, those are the two important things. And the third thing that I've just mentioned is the clinical variation issue and the GIRFT issues. This lists day cases, day surgery, but the GIRFT issues across the organisation are really, really important. So those are the things for me that we need to prioritise and make as our objectives. But as I say, aspirational, I think, is the underlying word.
I have a real discomfort with zero avoidable harm. I'm really sorry, but because I think rules is set to fail. I think that will make staff feel that way. And in preparation for this, I looked at organisations where they've been similarly challenged. The places like Aintree, you know, description like we strive to get it right first time, but when we make mistakes, we learn from them. You know, that's absolutely where I think we are. I think that's what we've talked about today. You know, and on that vein, I was looking at some of the papers in preparation for here and about medication errors, and you know, phrase of what was the what failing occurred. Well, you know, we're talking about culture and a learning culture, and actually, I think phrases like zero avoidable harm and what failed don't lead to that culture that we want. And as Andrew said, it has to be everywhere in the organisation. And I think we're talking about something that doesn't sit with what we're striving for. That's just my personal perspective.
At least we use the word aspire.
I know, but what does that say to the people?
Well, actually, I think everybody aspires to do no harm.
We aspire to do no. We aspire to get it right first time.
Yes.
That is a metric, zero, because it's a metric now. Zero avoidable harm, I think, is the. It's just a point of view.
John.
Yeah, I mean, this debate could go on. And we did have a fair bit of discussions exactly along the lines that you're saying. I think, so my personal view is that aspiring to no avoidable harm is a laudable aim. For me, it thereby implies all the other things that you are going to learn, because how you do that, you learn from your mistakes, you're open and honest, all that sort of stuff. But the other side of it is, well, so what is a level of acceptable avoidable harm? Is it 10 deaths a year, 20? So in another debate. So certainly said there is no right or wrong answer. But as long as we all realise that, your point is really important in that, how it all fits in with the big picture stuff, what we're trying to do with the culture, I think we're probably going to be all right.
From my perspective, what I'm trying to say is no avoidable harm. So if there is an instance in which we, God forbid, operate on the wrong limb, we go back and say, was the WHO surgical checklist carried out by the whole team appropriately, etc. if it was, then was that an avoidable or was it not an avoidable harm? So it is actually just, that's the headline, but there's all of that going on underneath. I just use the surgical checklist as one of the many examples of medicines, etc., across the organisation.
I think one of the things that's really key is how do we communicate, and I know Susie can't make it today, but certainly yesterday she was saying how important it will be to make sure we get the communication right, so that, because I agree with where you're coming from, it is difficult, but I also think it's really tricky to say, you know, yes, we're going to harm 10 patients, you know, I think that's quite hard. But we can weave all of that learning into the communication and make sure that it lands in that way. I think that's going to be really critical to work with Susie on how do we get the messaging right and how do we make it meaningful to people.
I don't just mean staff, I mean patients.
Yes.
You're right to mention the staff, but for me as well, you know, as a patient, zero avoidable harm. Oh, fabulous. And then I see a statistic that says otherwise. You know, and for me, another metric that could go in here is how we've managed our, just forgotten the words, where something doesn't happen, near miss, how we manage our near misses and the learning from that, because near misses are often, not always, often just go, oh, it's near miss, so you know, and the learning from near misses, that's a free lesson. It's the only free lesson we get. So I don't know, I'm happy that you've had the discussion. I'm happy that it was a debate, but I just needed to say so today.
So I think what's important here is about communication. I think there is a big piece of communication both internally on this and externally. It goes back to why would we expect there to be any harm if you're a patient? Why would you expect, you know, not what we see internally, what we understand internally is not what the population understands. So we've got to be clear how we communicate this. But in terms of an aspiration, that's what we're talking about here, but couched with all the learning lessons and the language on how supporting. So going back to your medication errors, big issue, how many medication errors is really low? Is that an indication of low medication errors, or is that an indication of a failure to actually register them? So,
or when we use the language, what failed in order for this medication error to occur? No, nothing may have failed. There's human factors playing in here. Why did it occur? Yeah.
So if we can, so that was the quality.
Just James, anyone to add on patient before we move on to the next committee?
I don't think so. The only comment I would say, Deborah, you're absolutely right, and the introduction of PSEF takes away some of that very inflammatory blame sort of language. So that should disappear anyway. But no, thank you, Karen.
Thank you. So moving on then to the final two, which are under systems, partnerships and sustainability, which Damien, over to you.
Yeah, so firstly, just to reiterate what Chris said, I think many of these things are the levers that drive quality and safety in the trust. I think my viewpoint is they're focused on the right things. So we talked about improving diagnostics. So the plans, I think, are very well aligned as you go through the pack. I won't go through them all, but outpatient transformation, theatre productivity, etc. So I think the plans are targeted at the right things that will drive improvement in terms of quality of service. I think our feeling in the committee when we discussed it is some of the targets are very difficult. So, you know, 92% bed occupancy is not something the trust has often achieved, I would say, or sorry, never. So these are very difficult things to achieve. And if I was to come on to finance, for example, the no unwarranted financial variation, well, we had a discussion about that earlier in the board, and that's not something that's been historically achieved too often either. So it's not to say these are the wrong things to be striving for, but I think we need to be realistic and say actually there isn't a good track record of achieving some of these things within the trust. And as long as we're sort of cognizant of the fact that these are difficult things to achieve, but I don't see any reason why we wouldn't strive to achieve them.
I think that's fine as long as we don't accept that they are
impossible,
difficult, and therefore there's an excuse for them not to be delivered.
Yeah. Agreed. I agree with that.
Anything else on systems? Yeah. And the last one.
Sustainability, which was covered in
Oh,
the
I've covered
committee,
that.
yeah. I don't know if John was going to add anything on that, yeah.
John.
So I think the metrics that we were, it wasn't even a metric, but the statement that we're making around unwarranted financial variation is so vague that we can't possibly either understand it or report it, because, you know, where do you start? So what we've attempted to do, or what I've attempted to do, is say there are a number of levers that we'll look at. One will be national benchmarking data, and our aspiration would be to move to median cost, i.e. in line with peers. And we would do that. So that data is only available normally on an annual basis. What we would seek to do is to work through our financial plan and be of the view that once we delivered our financial plan, we would then be in a better position against those metrics. So it's kind of a bit of a twofold, but it is nationally available data, it is comparable data, and it is data that we can present, understand, and do something with. And for me, it's got to be actionable, right?
And I think the rewording of S3 does that.
Thank you.
Yeah.
So then the board are asked to approve these as recommended by the committees, and then, as I say, he will be the communication, tracking delivery, and working out the plans in more detail. So we've got some real specific leads and dates. For
I'm
delivery.
assuming I'm not hearing any adverse. Sorry, Becky. No.
We're just getting a cup of tea.
I thought you were objected to approving. Nobody disagrees. No, they're approved.
Thank you.
Chair, can I just ask about accountabilities? Where do accountabilities for these sit?
Accountabilities sit with accountabilities for these ultimately sits with the board, but through the various committees.
And we've got the exec leads listed in here. So we've got the exec leads listed for each in here, and
So the execs are accountable for the delivery of these objectives.
well, no, so the leading.
He's nodding, and I'm saying, oh, no, I'd say, so from a, it's a good, so for example, about, I'll take the financial one, right, in terms of variation on how we use our resources. I think that I would be the executive lead for reporting and supporting, but it will be collectively our responsibility to deliver upon it.
Doesn't sound like it's clear, does it?
No.
So each of these work programmes will have, as we work out, so actually that's a point that was raised before at Northampton, each of these work programmes need a lead and timescales and the plans worked through. So we've got those, we need to just work those through and present those back at boards in May. Sorry, not boards, committees in May. That's the next step. That will help answer that question, I think, but you're not looking quite convinced. Right.
I think it would be helpful to have an executive who is accountable for each metric.
That's what I would have been used to in a commercial environment.
Because it can't be the non-execs. We're not here
No.
day-to-day operationally driving things. But
So it's
someone,
assurance over.
yeah, but someone has to be accountable, even if that accountability is reporting to a committee and saying, we didn't meet this because of these things.
Yeah.
Someone has to be accountable.
Sorry, can I just clarify? Do you mean accountable for each of the, so for example, quality as a whole, or do you mean for each of those programmes within quality? Because there might be a different exec for each programme. That's what I'm saying. There'll be an exec lead for each of those programmes within quality, and then overall, sorry. Overall, we've got the medical directors and nursing directors who, as John said, would be reporting that who would be responsible for reporting, but the actual accountability for each.
So I think what we're asking is
Might
at
not be
the
very clear,
committees,
No.
when that's presented to the committees, that there's clarity
Clarified.
clarity on who it is that's accountable for delivery. And I would then ask that those then need to be, this is in Debbie's absence, linked across to individual executive directors' objectives. Lise.
And it also means that each subcommittee needs to get at least a quarterly update on these programmes so that we can see the progress against
I
them.
hesitate to say quarterly,
Well,
regular update. I think we just got to agree what the updates are.
Yeah.
Some of them are nuanced in terms of the timescales, but yes, regular updates.
I was just going to request, given there are probably a couple of NEDs who don't sit on any of those committees, but sit on different committees, but I think this is so important, could we circulate that list of who is accountable, so we all know who to go to if we have any questions on any of those? Thank you.
Could it come back to the board?
It
Yes,
needs
yeah.
to come back to the board,
Yes.
so it needs to go to committee first,
Yes.
and then come back to the June board.
Yes.
Yeah, sorry.
So not to labour the point too much, but so certainly from the priorities that sit in under my leadership, they are in my portfolio. This is my job every day. So I would say I am accountable for the delivery of those. So I don't think it's as complex as we're making this discussion. I think it's, for me, these are already in my objectives, they're in my portfolio, and I am accountable for delivering.
Yeah, I'm not sure that's universal across all of those. That's great. I mean, that's what we want.
So I think that's just why we need them to go to the committees to make sure we're clear about who it is in each of these, and then that's in summary level and come back to the board in June. Thank you. Staff survey.
Yes, well trailed.
Well trailed, and I suppose the important thing when we come on the staff survey, where we've covered some things already, it's up to you in terms of whether or not you want to cover them again. But clearly we've got, this is very important in terms of the board understanding where we are with staff survey response, as well as the staff survey.
Okay. So obviously we had the opportunity at our recent board development session to go through the survey in detail. So just to pick out some of the highlights for Kettering in particular. So just a reminder that nationally the position was pretty flat this year overall in terms of all responses to the survey across the UK. There were a couple of areas that saw slight improvements in terms of team, we're a team and we're always learning, but everything else is pretty flat nationally. At Kettering, our participation this year was 43%, which was 1% less than last year, and certainly a good few percentage points less than our peak, I think it was 2 years ago, and just slightly less than the average. So it's disappointing to see that participation levels in our organisation weren't where they have been historically. And when we reflect on how we compare with that national position, none of the metrics in Kettering saw an improvement, and in fact some of them saw a deterioration. So Kettering performed worse than the national position, so we moved further away, and you'll recall that last year we also moved further away, having previously pretty much tracked the national trend over a number of years. We dropped more than nationally in the areas of compassion and inclusion, people feeling rewarded and recognised, always learning, and staff engagement. So some really important measures there for how staff feel in our organisation. Just picking up on race, we've seen some improvement in the race measures, which is really pleasing to see, and particularly measure 3 in the res, which is about whether more people from a BAME background are likely to be subject to formal disciplinary procedures, and we've seen improvements in that measure. But what is really concerning, and the board should note, is the experience of BAME colleagues suffering from discrimination. And we see that 25% of the BAME colleagues who completed the survey this time said they had suffered discrimination either from a colleague or from a leader in their part of the organisation. And that is a significant change. Back in 2019, we were at 12%. So you can see that there has been a significant deterioration in the experience of colleagues from BAME background in Kettering. To put some context around the survey, you'll recall we did the survey in the autumn last year. It came at the end of a really difficult summer, starting to clear the backlog and the pressures that put upon us. Plus we had a bit more COVID and we had high absence last summer. So, and it did feel as though winter hadn't really ended, didn't it? It was very difficult last year, I think, as we moved into the new sort of post-pandemic normal, if you like. And as we said earlier, it is disappointing that the results were what they were, given a lot of the initiatives that have taken place, and particularly Let's Talk in Kettering, which is a significant engagement programme, and we did a lot of work last year to gather views from our staff in terms of what they wanted us to do differently from last year's survey. And just picking up on the pulse, we did the pulse in January, so of course it's always interesting to see whether the pulse is correlating with what the national survey is telling us or whether it's different. Again, participation rates were very low in Kettering in January. That was similar to the national trend where most organisations saw very low uptake. We had 16% participation. Just to give you some reference point, last July it was 28%. Now quite often in January, you know, people aren't particularly interested in doing surveys and that kind of thing. Lots of people are taking some post-Christmas leave. It's not that long after the last survey finished, but again, 16% is not a very high rate. And we saw a decrease in engagement in the January pulse, and all the elements that make up engagement, so in terms of motivation, involvement and advocacy, they all dropped. Which, if you look at the graph of our engagement across the last 12 months, you can see a continual linear fall with each time we do a survey of our staff. Last year, we identified a series of priority actions around leadership and management, teamwork, reward and recognition, and respect. And we focused in Kettering on a number of actions, and each we had an overarching action plan in the trust, and then individual directorates had their own actions and those things that they wanted to work on. And we've done quite a lot of work on the culture in the organisation, as I say, in particular visibility, accessibility, and listening to our staff, and all the work that we did around falls last year really demonstrated how we got staff involved with making changes to our falls performance. We've identified and committed as a board to working on our culture, to working on QI, and to working on leadership and management, and all of those things remain the right things to do to support our staff and improve their day-to-day experiences. As I said earlier, we want to focus on embedding our values and bringing those to life for staff, and Susie and I have already started to have conversations about how we do that. I think it is really, really important that following the work that Karen's has taken us through, that we restate our priorities to the organisation and make sure it's really clear to all of our colleagues what we are all doing, what those priorities are, so that people can see how they fit and how they make a contribution to our joint efforts for our patients. And ultimately, we have to create that environment where staff understand the priorities, they're empowered to act, and they're supported to give the best possible patient care for the people who come and see us every day. So what we've been doing, we've been communicating the staff survey widely. We've talked already about the SLT work that's been going on. There's work going on out in the divisions where they've all got their own local results, and they can compare their results with other teams within the hospital. There's the planning that's going on around the discovery phase and how we're going to do that in the organisation, and that will come back to May for development. And finally, just to mention that the leadership and management offer that we have been working on, which is so important to make sure that we are supporting our new and aspiring leaders, but also those more experienced leaders who perhaps just need some additional support to think about how they lead their teams compassionately and effectively and supportively. Our new leadership and management offer, which is a UHM programme on 3 different levels, will be launched on the 17th of April and goes out into the organisations. And that's following a trial in Northampton last year and building on the success of that early work.
Question. David.
Yeah, I suppose a mixture of observations and questions. So I think my experience is low participation is quite often symptomatic of apathy, and that's driven from people feeling like it's not going to make any difference participating in the survey. There won't be any actionable change. So maybe that's something to think about. And then I think the other thing, again from experience, is you really have to understand the reasons why people are dissatisfied. And I don't know if you've got the mechanisms in place to do that, because it's about talking to individuals, I think, as well as focus groups and all that type of stuff. But unless you really understand the reasons why, you're kind of shooting in the dark as to what the remediation might be. So my question would be about those two two things really. What's driving the apathy? Do you really understand that? And have you got the mechanisms in place to really get under the skin of what's bothering people? Because as you say, although the national average was low, KGH was actually even lower. And then just a final thing, was it a surprise to the execs that KGH had moved backwards, or was it anticipated?
Before you answer that one, can you just pick up a couple more, just please?
Yeah, I'm really pleased that we're going back and trying to uncover the reasons, and divisions are starting to have those discussions about why are we where we're at. Are we allowing the divisions across the group to talk to each other? Because something that's come out recently is actually people who've worked in a ward for a while kind of aren't always aware of what others are aspiring to or behaving. So you lack that role model. So are we linking? So I'll take maternity services because I know they are talking to each other, but are we doing that for surgery and medicine to say, actually, what does a great surgical department or theatre department? And we can do that virtually. You don't have to get people in the same room, but I just think that would give us a kind of extra stimulus for teams to really think about what are we trying to do.
Andrew and Alice.
Yeah, we won't talk about culture. One observation is that, again, from my experience, action plans in these circumstances are better bottom up than top down.
Yeah.
And it's individual departments working, or individual areas working on their own particular action plans for their own particular areas, and I'm sure that happens. The other one is the question about racism, which is obviously disturbing. Through our listening channels, how do we investigate racism? And if we do investigate it, what's the outcome? What do we do?
Sorry, we'll just pick up Alice and then done with.
It won't be a surprise, because I know it's something I raised when we had the development day last month, but I guess I'm still a little bit, if I read this report and this was the first time we'd had this staff survey, I would understand where we are with the discovery phase and the champions and so on. Given that this is the second annual cycle of this, I feel a little bit frustrated, if I'm being honest, that we are still at the stage where we're saying we need to enter a discovery. We still don't have a commitment what we're going to do with the champions. And I realise there are reasons why, and John will no doubt raise his eyebrows from a finance point of view. I understand there are reasons, but it feels like this is either priority or it's not. And like reflecting on Damien's question, I can understand why staff might be saying this is the second one of these now and you're still thinking about discovery.
So I agree with you, Damien. I suspect that there is a bit of survey fatigue, but also a lot of what is the point, because things haven't changed.
Yeah.
And I think part of the well, there's two things, aren't there? A, you've got to change things, it's the first thing, but then you've also got to tell people what's changed and keep reminding them about what's changed and keep explaining it and bringing it back to the values and bringing that to life. So part of this is about a really effective engagement campaign, which again, I'm working with Susie and her colleagues on. And part of this is about having actions, to Andrew's point, that are the right things from the people who have identified what it is that is wrong. In terms of how we will know, the discovery work that we will do will be varied. So it will be some discussions with leaders, but it will be down to individuals as well, and teams, and the SLT will be deciding how they want to do that. Do they want to go across the organisation? Do they want to focus on some areas that are hotspots and do that? So we absolutely need to get out and talk to people and find out what it is that is impacting them. And we already have a lot of information. So we already have the information that comes through Freedom to Speak Up, through grievances, through the cultural survey that we're doing. So there's a lot of information we already have. And to your question about was it a surprise, I'll invite my colleagues to say what they think as well. I don't think it was a surprise, I think it was a disappointment. So last year we did invest a huge amount of time. We went and spoke to huge numbers of staff. We had the Whisper for a Whisper campaign where we went out into the divisions and got staff together and asked them what would make a difference. Governors came in and helped.
And I know Debbie personally did a lot as well.
Yes, and we got some really tangible ideas from people, and we had plans in place to put, to make some changes, and we've done a lot of work. But it's not making a difference. So that's why we need to really understand more about, well, why is it not then?
That's why I asked the question, because I suspect they were the wrong things.
One can only assume, yes, that is the logical conclusion. Yeah. In terms of sharing learning, you're right, we've got some real pockets of expertise, and I think that's in terms of teams that are really effective, but also individual leaders who are really good. And we need to be able to share learning and role modelling around that. And again, colleagues might want to comment on how we might do that in the organisation. Yes, local action plans, absolutely built from the ground up, which is what the discovery phase will do, and identifying those ambassadors to lead on that from across the organisation is going to be critical. In terms of racism, we have a number of different things that happen. So we've got the staff networks, and we have a reach network that meets regularly with us, who bring to our attention concerns. We've got our EDI colleagues who are focused around supporting all aspects of inclusion, but in particular racism. Clearly there are cases that come through the HR route, and there are also cases that come up through Freedom to Speak Up. We've recently done a review of racism related cases, and there's definitely some learning from my team in terms of how we handle things. And I'm very keen. Only yesterday we were having a conversation with some colleagues around moving, and it's been asked before actually in the boards. We've been looking at racism for a long time. How can we actually turn the dial on this and make a difference? And yesterday we were talking about actually moving to having an anti-racism campaign and having a much more proactive, formal stance around what we're going to do with a whole strategy that sits underneath that in terms of how we approach that in a number of different ways across the organisation. And I think we have to do that. We have to, as a board, commit to moving into a much more positive approach to being anti-racist, which will come through education, it will come through how we recruit, how we train, develop, support our leaders, and we need to have that commitment from here, and then a campaign that starts from bottom up and top down as well. And I think that's a critical priority for us.
Are there repercussions for people who engage in racist behaviour?
We have dismissed colleagues before who have been found to engage in racist behaviour, yes. Not often, we don't dismiss often, but we have dismissed. One thing, I mean, culturally again, my background is the police. In the police, when we did something like that, we publicised it as a message to all staff. This is what the consequences are if you behave in this way in this organisation. I'm not going to comment on the police because I've read other stuff. Whereas in the NHS, we don't do that. We do not publicly explain to people how we deal with significant poor behaviour like that. And it's something that, again, I would take Susie's advice as to whether or not we should be a bit more overt about the consequences.
So we as a hospital can make that decision, can we?
Yeah. And your final point, Alice, I share your frustration, as I'm sure you would appreciate. And I'm sure it feeds into Damien's point around inactivity. As you have alluded to, there are reasons for why we're still where we are. But I think when you see the plans that come to board development in May, I think you will feel assured that actually we've now got some traction.
I'm going to say it was short. Except
a comment and a question, actually, that's okay. So we agreed at the beginning of the financial year that we'd resource this. So resourcing was not the reason that we haven't moved it forward. I think we'll probably wait for a longer conversation on kind of understanding how we got to where we've got to. On the leadership development programme, sorry, I'm probably not as close to it as I might be. Are we targeting people to be on that programme? And if not, can we? Because we've got a number of senior leaders that have been jettisoned into a position with little support, and we're expecting them to deliver. And this would be one of those key areas that I think we said to them, you know, the expectations of you and your role are, and this is how we're going to help you do it, as opposed to just expect you to deliver.
Yes. So I've been very clear with my team that this isn't about sheep dipping, but neither is it about leaving it to people to, oh, well, I might do it or I might not do it. This is about leaders sitting down with their team members, identifying their own particular requirements and development needs in terms of leadership capabilities, leadership development needs, and then ensuring that they're on the right programmes. So it needs to be part of the conversation around development planning, and then people need to be supported by their leaders to attend the programmes. There are briefings going out to professional leadership groups, to the SLTs. I'm going to bring it to Jen in the next couple of weeks in terms of what programmes are, how to access them, but also your role as a leader in doing that personal development conversation, having the personal development conversation with your team members.
Yeah, and just to say, Debbie's view is very much as you've just said, Paula. Was it that we were really disappointed when the results came in, and I think it's fair to say there's been an awful lot of work that as execs and divisions that we have put into place. And I take your point, are we focusing on the wrong things? And I'll certainly feed that back to Debbie. Certainly, let's talk, and I know some of you have been to that. It's not hitting the spot that it was hitting. We are seeing less, well, actually probably similar numbers of people, but less conversation happening. It is definitely up for review, and talking to Debbie, that's definitely what we'll be doing over the next couple of weeks, because it's definitely not doing what we had set out for it to do, I guess. The other thing is around the networks. The networks are not functioning as well as they should be on this site, mainly because we've had people move on, etc. But I know Matt, who's now in the role, is looking at that. In terms of racism, Debbie is taking a personal interest in that one, and she will be chairing the REACH network, taking over from Andy Callan. So there has been some immediate actions taken in view of some of the feedback that we've had, but yeah, I think there's been an awful lot of effort, and certainly as an exec team would just like to assure the board that we are all committed to improving this, and collectively as a group of executives. And we've spent some time over the last couple of weeks looking at reflections, haven't we, in terms of what we need to do going forward. But we all do take this really, really seriously, and absolutely it's a top priority for all of us.
Could I just very quickly go on? I shouldn't have said I suspect that they're the wrong things. I've got no way of knowing that. What I really meant is you need to be sure that whatever the action plan is, it's the right things. So just for the record.
And that it happens.
And that it happens, yeah.
So there's a lot there, and we know there's a lot there. I think one of the most important ones for the board today was the statement about potentially, and I personally would welcome the change on the racism one. There was a debate, a development session about a year and a half ago when this came up, and we didn't go that far. Would that, as a policy, come to the June board? Could it come to the June board, or are we looking slightly longer ahead in terms of, when I say policy, I mean, we've got the policies and an approach. Is it going, it would have to go to the People's Committee first?
It would. My team's ready to go. We have a plan. So subject to my plan was, I think it's something that needs to go to board development session, potentially to have a good conversation about it. And I know that time on those committees or those meetings is pressurised. I don't know whether I'll be able to squeeze something in to the May one potentially to then come through the June committee cycle.
I was just going to say, surely we can just say at this board right now, we take racism very seriously, and we will be presenting a plan about how we are going to roll out our anti-racist plan. We don't need to make it overly complicated and say you need to go to this meeting, this meeting. We can say right now, we take a very dim view of it, and we will be, this organisation is anti-racist. We will have a plan about how we might roll that out through the organisation, but surely none of us is sitting on the fence on that.
I think we can make that statement. What I would say is, it's very easy to say that, to then be able to mean it and do something about it requires a
deep level of understanding, a good level of understanding, and that needs to be led by a board that is educated and has had a chance to talk
Yes.
about it. So I don't disagree with you that, of course, you know, no one's going to say that they're racist, but I think to commit to that policy requires an understanding of what we're signing up to, and so that everyone can be behind it.
So what would the timescales be?
Yeah, timescales on
So
that.
subject to getting into, I'm looking at Richard, to the board development session in May, I can come to board development, as I say, we're ready, and then I can come back to board in June.
I'm sure we will support you getting onto that committee.
So he's not flinching, is he?
You've got a slot on the staff survey, says whether we can
Shoehorn into that.
we can build it into that. There's a lot on for the 5th of May though.
Yeah.
It's absolutely packed.
Yeah. Yeah.
We'll find a way.
Okay, so I think we're, however, come June, we've got to find a way of getting this back to June, but totally in terms of, you know, we are not supportive of racist behaviour in this organisation, full stop. And how do we then ensure we support managers and all others in both calling it out and actually delivering the culture that supports that?
I mean, not to labour the point here, but I think it's what are the consequences of it if the case is substantiated. That's what needs to be communicated. In most workplaces, I think it is dismissal for gross misconduct, right? So I think we need to get to that as well. What are the consequences of it? And how do you publicise that?
And we have some case studies that we can anonymise where we have this.
We now need to move on to the group governance arrangements. Richard.
Thank you. So 2 main aspects. I'll take the committees in common first, if I may, and update you based on, I guess, my understanding of the discussion at Northampton yesterday, and welcome obviously group colleagues who were there yesterday to tell me whether I've captured this correctly. So the ask of the boards is to review the piloted resumption of in common working for the quality and finance committees, which has happened in January, February and March, and asked the boards to decide whether you wanted to make that move permanent. So the Northampton board discussed this in some detail yesterday, and whilst they were supportive of the longer term principle of moving to full in common arrangements, they had some reservations, I think, again, in terms of embedding subgroup reporting and embedding some of the improvements to the IGR. They felt more comfortable to, rather than to make the move permanent, to extend the pilot for another 4 months and take another look at the July boards, and that would enable us to do another workshop to follow up the series of workshops that we did during the development phase next year, at which we can try and do as far as we can a quantitative and qualitative assessment against the new terms of reference. So part of this recommendation you'll see in the report is that the quality and finance committees have obviously both done lots of work to review their terms of reference and their membership. So we will have a new set of terms of reference against which to judge. So that was the view of the NGH board, again, to revisit this in July. If we are, as the NGH board did, they were happy to approve the terms of reference subject to a couple of minor changes that are being agreed with chairs around membership and some of the nuances of the wording. If you're agreeing the terms of reference, the committees in common are taking the responsibilities of the trust only committees. So the implication of that is that the trust only quality and safety and performance finance and resources committee would be abolished because their responsibilities have been completely subsumed by the committees in common, with the caveat or the safeguard that these are still committees of each trust, so there's still scope if circumstances dictate or require for the committees to meet separately. So I just wonder whether to pause it there and just open a debate around the committees in common.
Jackie?
So I think there was a different discussion around finance and performance committee in common than there was around clinical quality Safety and Performance Committee in Common. And there was agreement for the Finance and Performance Committee in Common to be made a permanent committee in common. That was my understanding of the discussion we had yesterday. I'm just slightly looking at time.
There was universal agreement that it would be the right thing to do, but it was not agreed as a way forward.
For the Clinical Quality Safety
Get on to why in a second.
Performance Committee in Common, there was quite a lengthy discussion around there being a commitment to having a committee in common for that, a recognition that there has been benefit in terms of learning between the two hospitals. However, there was some discussion about differences between the subgroups and whether or not the IGR fully supports that committee. There was a bit of debate about whether or not it should be a move to a permanent committee in common with a review point, or a continuation of a trial for a fixed period of time. And there was so Jill, Andre wasn't there yesterday because it was holiday, so Jill was representing the NEDView from the committee, and she was quite clear that there was a unanimous discussion in the Clinical Quality, Safety and Performance Committee in Common that they wanted to continue on a permanent basis. And we ended up in a discussion around that, and the discussion landed in a place of let's continue the pilot, with a caveat of whether it's a pilot or whether it is permanent with a review, that there is a commitment to making it work as a committee in common. Perhaps John might.
John, are you going to say about the finance?
Yeah, so I mean, I think it's fair to say there was quite a visceral steer from members of the quality committee that there had been that conversation, and they were very, very clear that not adopting it moving forward, not adopting it permanently moving forward would be against that conversation that happened. And so I think it's fair to say that. I expect there'll be some conversation in a second about that. But the other main reason, and I think if you kind of step back from the emotions or about the objectiveness of it, it was have we at this point done a full review of the benefits of in common working versus any disbenefits, and have we done that step back in a transparent kind of way and kind of weighed those two things up? And I think the conversation yesterday was no, that isn't what we had set up. We said let's run it to see how it goes and we'll take stock. Not have we in an objective way kind of said what does flying at this level versus this level mean for us. And there was also some wider nervousness from some of the non-execs at Northampton around how those in common arrangements would then report into our separate boards. And I think it's fair to say we had the conversation that said we are on a journey. The journey that we have laid out and an endpoint is a board in common, if I've got the right terminology. And therefore this is a stepping stone set of arrangements to that, and the kind of stock take that was discussed and agreed. And we did say you'd be interested if we don't agree this at Kettering as well. This is part of the challenge that we've got, right? That in advance of making a decision to move to a board in common, you would want to assure yourselves that the committees are operating as effectively as they might, and we're all collectively in the same place there. So that was the kind of the wider context.
John.
I'm going to caveat what I'm about to say, that with I'm a new boy, excuse. So stop me if this isn't the place to have this conversation, it should be had outside there. But if we are serious about collaboration, is this not an absolute fundamental step that we've got to take? And I'm just hearing a lot of what some used to call whattiness. You know, we're not having the right conversation somehow. You know, the right conversation is, are we committed to collaboration or not? And my gut feeling, having been here for 2 months only, is that I'm hesitating there. Kettering are committed, and Northampton maybe not quite as committed. Is that?
I don't think that's. Can I respond to that, Chair?
Yes.
I'm not sure that's fair. I think the challenge on, to use your term, whattiness is an extremely reasonable one. I think that we then move ourselves into a place of, are we all clear about what that future journey of collaboration looks like? And I think as we move into the private session this afternoon and we have some of those further conversations about what that might look like in the coming kind of 6, 9, 12 months, that will come to a head. So I think it's a reasonable challenge. I think there are legitimate reasons as to why that question's been asked, and I don't think it's through a lack of willingness or engagement. It's something else.
Louise in June.
So, my perspective on this is if you look at every external review where a service has failed, and one of the consistent messages is inward looking, not outward looking, lack of comparators. So I think the Quality Committee in Common is a really positive step because you actually have services looking across units and challenging each other. And that's what the urgent care report is doing. That's what the maternity services. We really see services that are starting to talk and start to have different conversations. And Faye, Jane, you can correct me if I'm wrong on that. I think a view that says any board subcommittee can really be in the detail is missing the point of a board subcommittee. A board subcommittee is there to gain assurance around programmes of work, but also the governance structure. So we need to be assured that the subgroups that the execs sit on, that do the operational day-to-day management and manage the medium-term agenda are robust. So I think there was a query at the Quality Committee about actually how robust are the subgroups. And I would support a piece of work that says actually we need to, they don't have to be aligned. Actually, they don't have to be the same. But actually what we as non-execs need to assure ourselves is that however KGH structures its subgroups, actually it is covering the full scope of the quality agenda, and similarly in NGH, and that those groups are working well. So I think a challenge to us was to ask the subgroups to really look back and say, what have you changed? What risks are you managing? Is a good one. Does that require the Quality Committee in Common? I wish we could find a shorter word. To stop? No, I don't. And I absolutely support John's view. If we start havering and saying, are we going to or not, the signals that it sends to the leaders of the cardiology and the ENT group are, why are we bothering? Because actually it might be that they're peddling back. So I would fully support that Quality Committee in Common goes forward, as with finance and performance, but that each committee in common looks at its subgroups and say, have we got the assurance, the robust governance coming up to us to be able to give a limited, reasonable or substantial assurance view on the scope of our work?
Jane.
Chair, I'm going to frame my response slightly differently. So we're here to serve our local communities, our local populations, and deliver the best healthcare we can across our patch. Building slightly on Lisa's point, we can't do that if we only look internally and look at our own envelope. We have to look across. And what I've seen since being in post is a real sharing of not just when things have perhaps not delivered what we hoped they would, but also when things have delivered more than we thought they would, and how we learn from each other around that. And certainly that to me has been, and there's lots of examples I can give around that, around safeguarding, infection control, some of our emergency services, as well as the sort of clinical, that big ticket item things that John's referring to. And I think for us as a relatively small organisation, it's so important that we have that check and challenge and peer support down the road. I think it's invaluable. I absolutely we've discussed at length about the challenges with the report, and a lot of that work that sits in the report actually sits within that nursing metric basket. That's where some of this is not comparing apples and apples, but certainly we're lining up things like safeguarding policies, we're lining up complaints policies. It's an awful lot of work we need to do to get that IGR lined up and level, I wouldn't want to do that for a further pilot, because I think if we're going to put all that in, we're committed to picking this up and it being a permanent structure. I think it's the right thing to do for our patients and the right thing for our staff.
Natalie, Deborah, then I need to.
Yeah, I think I would echo what colleagues have said, and I think I certainly left our last common meeting with a very clear steer that we had agreed that we wanted to keep meeting on that basis. I think it's coming back to John's point that for me it's about where the default is, and I think the default should be we are all working as committees in common unless we have a very clear reason not to, and I don't think we have a clear reason not to. I think we've got things that we can learn and investigate, but I don't think that's a reason not to.
Deborah.
Actually, the committees in common as well support our licence agreement, which says that we should be integrating for improvements in quality and reduction in inequalities. So actually, honestly, both organisations can go tick without any worries at all, provided that we are signed up to it.
So what I'm hearing is that we totally support moving forward with the committees in common. What I'm also hearing, it may be slightly different between the business and finance and the quality committee, is that there are areas that still need development. So the development about subgroups, mapping the subgroups, something that's come up earlier, which I think is still relevant for this as well, is where the IGR supports the committees, and there's further development work there. So with those two areas that need to be reviewed, I would say that we put that onto, though we really need to have that review done in the next 3 months. That we should be saying within 3 months' time, we should have we should have reviewed where the subgroups are, because in some cases maybe there should be less subgroups, but it's actually knowing which subgroups there are and what their functions are, etc. And totally, they may not be the same in the two organisations, because they are two separate organisations. But that we then, at the same time, and this is not about and not saying we're not doing the committee in common, but actually just demonstrate what have they done for us. So going back to the all that's been rehearsed here about the working together, the development, the sort of joint reporting, I think will be a greater body of evidence in 3 months' time with the sharing of working, and whether that's maternity, whether that's the collaboration groups, and I'm sure finance sort of allows itself more to be sort of joint, but some of the performance things, how we do things in the different sites working across. So I think not the same as NGH, just for clarification, but actually that we need to be clear about what we still need to do to further improve the joint working committees in common, rather than say this is a pilot and we're going to extend it for another 4 months. Seeing nods around the table, is that? Yes.
Could you just say that again, Trevor?
Sorry, Chris. So what I said was committees, I used the wrong word phrase somewhere in there, committees in common to be the standard, that at the same time that we will be reviewing what the IGR implications are to further support them. We'll be looking at any subgroups, and it varies from different committees how that works, and that we will do a piece of work that demonstrates the benefits of the committees in common.
Is the committee in common of quality, safety and performance being made a permanent feature?
That is
yes or no?
That is what I am proposing. Sorry, Chris, if I was not clear.
Okay, thank you.
No, I think we've got to be. That is what I'm hearing around here.
If it's not being made permanent, I object. Be absolutely clear.
Yeah, but that's what I'm hearing from not just you, Chris. I'm hearing that from others, and I heard that the members of the committee, which is where I'd started previous discussion about this, members of the committee should be the key arbiters of whether or not they want to continue with the committee in common, because they are sitting there. There will be a view from the audit committee in the longer term, reviewing about the assurance. That's not to say that the committee in common doesn't continue.
Presumably, Trevor, we can, it's a marriage, isn't it? So, you know, we can say we would wish it to. Presumably, we don't have the power here today to say it will be if our partners are not comfortable.
No, we need to do that jointly, and that's part and parcel of working together. Marriage is, we'll use that as an analogy.
Yeah, so just one thing. So, yeah, I agree the committee in common should continue for performance and finance, but insofar as benefits goes, the main benefit at the moment is, being honest, comparison between the two sites. There isn't actually a lot of joint work. So I think the benefit of the committee will evolve over time, and that is inextricably linked to the Seagrave report and what we choose to do about that in terms of the future direction of the group. So I just want to be clear, if you're going to do a benefits review of PF&R right now, it's mainly going to say, well, we can look across both sites and see what's going on. And John does a little bit about the wider system from a finance point of view as well. There isn't a huge amount, I don't think, of kind of joint projects, that type of stuff going on.
So I would suggest, therefore, the review should be both retrospective and prospective.
Yeah.
And that's not just finance, that quality, because I'm sure there's more work to be done on where we can get additional benefits out of this.
Sorry, can I just add that
I'm going to say people's committees.
some caution, because if we lose any of these, it spells there's a risk to all of them. And right now, the people committee does make a huge difference. We've got policies in common. We've got joint working and looking at our workforce so they can work across the county. I think there's a real risk if any of these don't succeed, if I'm honest, and I think they should all succeed.
Yeah, thanks. And just in kind of marrying it, as to use your phraseology, that in practical terms, we're committing to committees in common for the next 4 months, and that we'll bring the results back for the review that you described.
No, that's not what I'm saying.
I think we're in a different place to Northampton.
So we think we should have a review. We should be doing the piece of work, reviewing what we need in terms of subcommittees. The IGR is what we'll be coming back on, but not that the committees in common are per se are the what we're reviewing. What we're reviewing is what the feeders are and the outputs are.
So that's slightly different way. So, but is there a time frame for bringing back the results of the review that you're describing?
I said 3 months.
Right, which ties it. Okay, that's fine. Thank you.
And so committees in common don't rest on that. Am I clear?
Yeah, no, the committees in common don't rest on that, but we've heard that the subgroups is a piece of work that needs to be done. We've heard that the IGR still work to be done. So I think we should be saying, how do we make the IGR fit for purpose for the subgroups to use? It may not be about delivering all of that in 3 months' time, but actually what needs to be done to deliver that. And lastly, that benefits realisation piece. This is what it's delivered. You do your benefits realisation piece after you've delivered the project. You don't do it and say, well, we're actually not going to build this hospital because the benefits haven't been sort of delivered. You set it up, you run it, and then do your benefits realisation.
And surely this should be the first of many annual or biannual reviews that these committees in common.
Could I just ask a clarification question, Chair? Because I think in Richard's introductory remarks about Northampton yesterday,
it's very different.
He was saying that actually they're not committing to them permanently. They're going to do a review in 4 months and make a decision as to whether to continue going forwards, which is fine. We can't sort of reopen that here, but I just want it to be clear that there's a difference in opinion.
So we need to have a conversation across the two organisations. Yes, Chris.
Thank you.
Can we now be clear who is accountable for delivering those reviews? Who's going to deliver the reviews of the subgroups? Who's going to deliver the review of the IGR?
I think that probably requires Richard Apps to be in the room, doesn't it?
Yeah.
Because I know he was planning a review of the work programme.
So we will come back shortly on that out of session to the committee chairs and the committee members.
Could I give notice, Chair, that I'd like to raise something in the private meeting of a confidential nature relating to this subject? It wouldn't affect the decision, but it is a remark that needs to be discussed.
We do need to press on now. I failed in my one task of finishing the meeting. Fit and proper persons.
Sorry, Chairman. Sorry, boards in common. There was the second part of that report was to defer consideration of the boards meeting together until third quarter of this year. Consensus on that. Thank you.
Yes. Fit and proper persons annual return. Are they all in now?
Yes.
Yes.
100%. Thank you.
And there's no issues.
No issues.
No issues. So we note that the fit and proper persons return has been complete. Returns have been completed, and that will be kept by governance team. Just the governance team. Yes. Yeah. Annual self certification. Noting that there have been changes in the way this works, actually not that much as much changes for us as a foundation trust as it would be for an NHS trust. But you have a report going through the various areas. Is there anything in that report? I know it's down for Richard, but is there anything in that report that anybody has any contention with the assertions that have been given in the self-certification report? No? It is something that, as I say, as a foundation trust, we've always, since about 2012, 2013, we've had to do in terms of our licence requirement. And now it's been sort of spread wider so that NHS trusts also have to complete this. But it is a piece of, it's not just a tick in the box, you know, it is about actually being assured that actually we are meeting these requirements. Yes, we've seen nods around the table. Thank you, Richard. And finally, appointments. I think we've covered a number of these before. So in terms of the Council of Governors approved my appointment as interim chair. Chris has agreed, whilst I'm the interim chair, to stand into the vice chair. I don't think I'm quite twisted his arm, but
Well, after what happened last time, but you did.
You handled that very well last time, so I'm not planning any great event this time. That's the last one. Appointment of Andrew to the group finance and performance committee. Appointment of Andrew to co-chair the transformation committee. And for the 3 months I'm chair, for Alice to be the chair of the audit committee. And Andrew has agreed to be the third, it's a lot of Andrew, the third member of the audit committee.
2 meetings.
For 2 meetings. No, for 2 meetings. So are all those approved?
Yeah.
Any questions from members of the public? No. Any other business? No. And meeting closed, and resolution to exclude the public and press. Is that passed? Thank you. And just before we come on to the second meeting, Mara will be joining us in the second meeting for an update on SUIs in maternity. So it wasn't on the original agenda. Sorry?
Can we Is she high up on the agenda? Because I know it's actually an annual leave day for us today.
Yes. Yeah. It was her request.
Yeah, I know. I'm also conscious that.
Thank you. We'll break for lunch.
Should be next door.
Should be next door. If we can make it 25, yeah, 25 minutes. I'll make it 30 minutes.
It's really generous.